It's time for another warm-up review. Let's get going. What gastrointestinal problem is most likely associated with each of the following scenarios? So first we have a 50-year-old woman, pruritus without jaundice, positive AMA. This is going to be classic for primary biliary cirrhosis. Next we have GI bleeding, buccal pigmentation. That's going to be Peutz-Jeghers syndrome. Next, we have a 60-year-old woman, rheumatoid arthritis, no alcohol history, fatigue, right abdominal pain, elevated ANA and ASMA, elevated serum IgG levels, no viral serology markers. So this is going to be autoimmune hepatitis. Next, we have 23-year-old woman, no alcohol history, elevated levels of LKM1 antibodies, no viral serologic markers, liver biopsy with infiltration of the portal and periportal area with lymphocytes. So this is going to be autoimmune hepatitis again. So there are a lot of different ways that you could steer you towards the diagnosis. They might give you the classic clinical presentation, they might give you the serologies, or they might give you the biopsy. Next, we have fatal disease of unconjugated bilirubin resulting from a complete lack of UDPGT activity. That's going to be the Crigler-Najjar type 1. All right, that's it for the warm-up. Let's get to that lecture now.
Over the course of the next few videos, we're going to talk about blood pressure. We'll talk about chronic hypertension and various antihypertensive drugs in the next couple of videos, but right now we're going to start by discussing how the body regulates the blood pressure. It's pretty basic stuff, but it's important conceptually. Your body needs to maintain the blood pressure high enough to perfuse the tissues and oxygenate, but not so high that it causes end organ damage. There are two main mechanisms the body uses to maintain the blood pressure. The sympathetic nervous system, which is sort of a short-term blood pressure control mechanism, and the renin-angiotensin-aldosterone system, which is more of a long-term mechanism. Let's talk long-term first. We discussed the renin-angiotensin-aldosterone system in the video on CHF, but to recap, when the kidneys sense low blood pressure at the juxtaglomerular apparatus, they secrete the enzyme renin. Renin cleaves angiotensinogen into angiotensin 1, and then angiotensin-converting enzyme converts angiotensin 1 to angiotensin 2. And angiotensin 2 has two functions. It tenses angios, so it's a potent vasoconstrictor, and that raises blood pressure. And it also stimulates the adrenals to make aldosterone, and then aldosterone causes sodium and water retention. And that sodium and water retention expands the blood volume and raises the blood pressure long-term, but not short-term. Then the short-term mechanism of blood pressure control is mainly the sympathetic nervous system. Basically, you have pressure receptors or baroreceptors in the carotids and in the aorta that sense the blood pressure and send signals to the medullary vasomotor center. And that sends a sympathetic signal that increases vasoconstriction and increases your heart rate. Let's talk about what that looks like in a little more detail. These baroreceptors are basically sensing stretch in the walls of the vessel, either stretch in the wall of the aorta or stretch in the wall of the carotid sinus. Now, when the baroreceptor in the aortic arch senses a change in the blood pressure, it transmits a signal to the solitary nucleus in the medulla via the vagus nerve. And the baroreceptor in the carotid sinus sends its signals to the solitary nucleus via the glossopharyngeal nerve. So when the blood pressure decreases, there's less stretch on the walls of the aorta and the walls of the carotid, and that decreases afferent baroreceptor firing. And those afferent nerves are cranial nerve 10 for the aortic baroreceptors and cranial nerve 9 for the carotids. And then where do the signals go? To the solitary nucleus in the medulla. Then the solitary nucleus decreases efferent parasympathetic stimulation. Now, what's the main parasympathetic nerve that slows down the heart? It's the vagus nerve again, cranial nerve 10. So this low blood pressure signal is going to decrease firing of the vagus nerve at the heart and the vasculature. And at the same time, there's an increase in efferent sympathetic stimulation. Now, which adrenergic receptors cause vasoconstriction? Alpha-1 receptors primarily. So this increased sympathetic signal will increase alpha-1 vasoconstriction and also increase heart rate and heart contractility by stimulating beta-1 receptors. And all that will raise the blood pressure. Now, this sympathetic pathway is an important response to severe hemorrhage. If you start to bleed out, the heart rate's going to increase very quickly and the blood vessels are going to clamp down. Again, this is a short-term mechanism, so your body's going to do this right away. The system can react very rapidly to hypotension. On the other hand, if the blood pressure increases, the baroreceptors sense increased stretching of the arterial wall, and there's increased afferent signal to the medulla. That leads to increased efferent parasympathetic signals from the vagus nerve to the heart, and that decreases the heart rate, so the blood pressure drifts downward. Now, one way we use this clinically is in assessing and treating a patient with supraventricular tachycardia. If the heart's going fast, you ought to be able to tell it's supraventricular because it's a narrow complex QRS. But you might not be able to say for sure what the underlying rhythm actually is because the heart's just beating too fast. Well, one bedside treatment is to perform something called a carotid massage. So you apply some pressure to the carotid bulb, and this causes increased stretch in the carotid, and that tricks the body into thinking that the blood pressure is elevated, so that the vagus nerve will tell the heart to slow down temporarily, and then you can see what the underlying rhythm is on the heart monitor. Now, the baroreceptors are also responsible for something called Cushing's reflex, or sometimes it's called Cushing's triad, or the Cushing reaction. So this is where you have increased intracranial pressure for some reason, such as intracerebral hemorrhage or an epidermal hematoma, or maybe from head trauma. And that increased pressure is constricting the arterioles in the brain and causing some cerebral ischemia. Now, the hypothalamus senses that ischemia and stimulates the sympathetic nervous system, which leads to alpha-1 vasoconstriction and elevated blood pressure. The aortic baroreceptors sense this rise in blood pressure, and the increased vagal tone leads to reflex bradycardia and some respiratory depression. So this is one of the unusual things about Cushing's reflex. You're combining hypertension with bradycardia and also respiratory depression. Normally, hypertension is associated with tachycardia. But if somebody comes to the ER with a triad of hypertension plus bradycardia and some respiratory depression, think about increased intracranial pressure. That's Cushing's triad. So that's pretty much it for the baroreceptors. But the carotid bodies and the aortic bodies also have chemoreceptors. So these are peripheral chemoreceptors, and they respond to low partial pressure of oxygen in the blood. That's the oxygen that's dissolved in the blood. So they can sense hypoxia. They can also sense hypercapnia, or elevated partial pressure of CO2. And they can sense acidosis. Now, the brain also has some chemoreceptors. They're found on the surface of the medulla. And these are called central chemoreceptors. Now, these respond to changes not in oxygen, but they do respond to changes in CO2 and pH, but not in the blood. They're responding to changes in the chemistry of the CSF and the interstitial fluid of the brain. So brain pH and brain PCO2 are both influenced by arterial CO2. So hypercapnia and increasing PCO2 will cause a response in these central chemoreceptors, but these do not respond directly to oxygen. But all these chemoreceptors aren't really affecting the blood pressure much. They're primarily affecting the respiratory rate. One of the most important ways the body can regulate the blood pressure is through vasoconstriction. Now, to understand vasoconstriction and vasodilation, we need to talk about smooth muscle contraction and smooth muscle relaxation. This is a really complicated diagram, but it's highly testable, and it's clinically relevant because it helps you understand the mechanism of a lot of blood pressure drugs. We're going to start with the end in mind and work backwards. Basically, this diagram shows a smooth muscle cell on the right, and on the left you have an endothelial cell. So let's start with the smooth muscle cell. And over here on the far right you see contraction and relaxation. Let's start with contraction. What causes vascular smooth muscle cells to contract? Smooth muscle contraction is caused by myosin phosphate interacting with actin. Now, myosin phosphate is just myosin that's been phosphorylated. And the enzyme that phosphorylates myosin is called myosin light chain kinase. Enzymes that phosphorylate things are called kinases. So myosin light chain kinase phosphorylates myosin. And then the thing that stimulates myosin light chain kinase is the complex of calmodulin and calcium. So this calcium-calmodulin complex stimulates myosin light chain kinase, which phosphorylates myosin, and that causes smooth muscle contraction and vasoconstriction. Calcium channel blockers, specifically dihydropyridine calcium channel blockers like nifedipine or amlodipine, disrupt this process. Calcium channel blockers prevent calcium from entering the cell, so this calcium-calmodulin complex can't form, and myosin light chain kinase is not stimulated. So instead of smooth muscle contraction, you get smooth muscle relaxation and vasodilation and a decrease in blood pressure. So that's how calcium channel blockers work. Cyclic AMP will inhibit myosin light chain kinase. Beta-2 stimulation and prostaglandin E2 will increase cyclic AMP, so they inhibit myosin light chain kinase. And if you inhibit myosin light chain kinase, you're going to inhibit smooth muscle contraction and cause some vasodilation. We mentioned again and again that prostaglandins keep vessels open, such as giving a prostaglandin to keep the ductus arteriosus patent in certain types of cyanotic congenital heart defects. And this is the mechanism by which that takes place. So again, three things that affect myosin light chain kinase: dihydropyridine calcium channel blockers, epinephrine acting at the beta-2 receptors, and prostaglandin E2. There's also a substance that dephosphorylates myosin phosphate, and that's myosin phosphatase. So kinases add a phosphate group, and phosphatases remove a phosphate group. So when myosin phosphatase is activated, it removes that phosphate group, which is going to cause smooth muscle relaxation. And working backwards, what activates myosin phosphatase? That's cyclic GMP. The enzyme cyclic GMP phosphodiesterase deactivates cyclic GMP by converting it to plain old GTP. So again, working backwards, more cyclic GMP is going to cause more smooth muscle relaxation. And more activation of the cyclic GMP phosphodiesterase will cause less cyclic GMP and more smooth muscle contraction. So cyclic GMP phosphodiesterase inhibits smooth muscle relaxation. Drugs like sildenafil or Viagra are phosphodiesterase inhibitors. And they result in more cyclic GMP and more relaxation. That's how drugs like sildenafil cause vasodilation. But if you want more cyclic GMP, nitric oxide works by activating the enzyme guanylyl cyclase, which in turn converts GTP to cyclic GMP. So nitric oxide activates guanylyl cyclase, and that leads to vasodilation, which makes nitric oxide one of the body's most important mediators of vasodilation. Nitrates, like nitroglycerin, work by releasing nitric oxide in smooth muscle cells, ultimately causing some vasodilation. This is why you should never give a patient sildenafil if he's also taking nitrates, because you're going to cause a double whammy, 2 hits on the same system, leading to serious vasodilation and potentially dangerous hypotension. Working backwards from nitric oxide, you can see that L-arginine or levoarginine is a precursor to nitric oxide. There's an enzyme inducible nitric oxide synthase, or INOS, that converts arginine to citrulline plus nitric oxide. And there's lipopolysaccharide, or LPS, that stimulates nitric oxide synthase. This is how gram-negative bacteria cause vasodilation and sepsis via these lipopolysaccharide endotoxins. And then finally, over in the endothelial cell, you see that vascular endothelial cells have a nitric oxide synthase called eNOS, for endothelial nitric oxide synthase. And this isn't inducible. eNOS is constitutively expressed. It's always expressed. So eNOS converts levoarginine to citrulline plus nitric oxide, and then the nitric oxide seeps over to the adjacent smooth muscle cells, and it causes vasodilation. And there are a bunch of things that activate eNOS: bradykinin, acetylcholine, alpha-2 agonists, histamine, serotonin, and shear stress. So all these cause vasodilation by increasing intracellular calcium and increasing generation of nitric oxide. Even serotonin, which we think of as a vasoconstrictor, it does stimulate this endothelial NOS. So there are lots of different drugs that affect this pathway at different places and lead to vasodilation and smooth muscle relaxation. Now this pathway is very high yield for your exam, especially with regard to nitric oxide. Another important chemical besides nitric oxide that mediates vasodilation a little bit is called atrial natriuretic peptide, or ANP. So it's very similar to the brain natriuretic peptide, or BNP, that we talked about with CHF. ANP is a hormone produced in the atria of the heart in response to increased atrial volume and increased atrial pressure. So the atria gets stretched, and then they start releasing ANP. And just like BNP, ANP has 2 effects. It's a vasodilator, and it's also a natriuretic peptide, so it causes a diuresis of both water and sodium. And it does this by acting on the afferent and efferent arterioles in the renal glomeruli. It constricts the efferent arterioles in the kidney, and it dilates the afferent arterioles, which is going to increase the GFR and promote diuresis. So you can think about ANP counteracting the effects of aldosterone. Instead of retaining fluid and expanding the intravascular volume and raising the blood pressure, ANP causes diuresis and helps to reduce the blood pressure just a little bit when the atria become overfull. And you may want to write in that both ANP and BNP act on the same receptor, which is called natriuretic peptide receptor A. There's also NPRB and NPRC, but the main one is NPRA. So NPRA, or natriuretic peptide receptor A, is a transmembrane receptor that has guanylyl cyclase activity. So when ANP or BNP bind the receptor and activate the guanylyl cyclase, it results in increased cyclic GMP, and that's how ANP and BNP cause vasodilation. That fact does get tested, so make note of that. Even though the kidneys and the sympathetic nervous system regulate the blood pressure globally, certain organs can influence blood flow to themselves through a process called autoregulation. So let's consider how autoregulation works in 2 organs, in the heart and the lungs. In the heart, you have local metabolites like CO2 and nitric oxide and adenosine that determine whether the coronary arteries and the arterioles are constricted or dilated. So if the heart tissue is underperfused and CO2 starts building up, the coronary arteries are going to be dilated to bring more blood to the tissue. And then nitric oxide, that important vasodilator mechanism, also helps to maximally dilate the coronary arteries. Now, this is kind of a confusing point for a lot of medical students because we give nitrates like nitroglycerin to treat angina. So angina is due to myocardial ischemia, an inadequate oxygen supply, right? Well, a lot of students think that nitroglycerin improves myocardial oxygen delivery by dilating the coronary arteries. But that's really not the case, because if your heart is starving for oxygen, then your coronaries are already going to be maximally dilated. It doesn't matter what you give the patient, you're not going to be able to dilate those coronary arteries anymore. They're already maximally dilated. So, how does nitroglycerin relieve angina then? Well, nitroglycerin causes systemic venous vasodilation. That's going to reduce the preload to the heart, and ultimately this decreases the myocardial oxygen demand. Now, don't get confused by that mechanism. Sublingual nitroglycerin reduces preload, and that reduces oxygen demand. It's definitely high yield, and I guarantee you're going to be pimped on that during your internal medicine rotations. And then, how do you think adenosine would affect coronary blood flow? Well, think about where else in your body you see adenosine. Well, it's part of ATP, right? So your body senses adenosine as a starvation molecule, so to speak. The body sees adenosine around. It's telling your body that you've broken off all the phosphates from that adenosine molecule. You've used up all your adenosine triphosphate, all your adenosine biphosphate, even monophosphate. So if you have just plain old bare adenosine, that communicates an energy-starved state and a need for oxygen. So adenosine is a very, very potent vasodilator. And that's why patients get that flushing reaction when you give a little push of IV adenosine in the treatment of supraventricular tachycardia. Then the only other thing I want to mention about autoregulation is that hypoxia in the lungs causes vasoconstriction. We talked about this back in pulmonary. Anywhere else in the body, hypoxia causes vasodilation. So if you have myocardial hypoxia, your body reacts by increasing the diameter of the coronary arteries to get more blood and more oxygen to that area. But in the lungs, this would be counterproductive. You would be increasing perfusion to areas of the lung that are not very well ventilated and not well oxygenated. And then that poorly oxygenated blood would be circulated throughout the rest of the body, so that's no good. So instead, the lungs represent a self-sacrificial system that benefits the rest of the body. Instead of hypoxia causing vasodilation like it does everywhere else, hypoxia in the lungs causes vasoconstriction. So you clamp down the vessels going to that poorly oxygenated lung tissue. That's going to deliver more of the pulmonary circulation to the well-oxygenated tissue. Now let's go over the end of session quiz. All right, the first item says, outline the mechanism by which the kidneys regulate blood pressure. So first, the juxtaglomerular apparatus senses low blood pressure, and that stimulates the production of renin. The renin converts angiotensinogen to angiotensin 1. And then in the lungs, angiotensin 1 is converted to angiotensin 2, and the enzyme that does that is angiotensin-converting enzyme. And then angiotensin 2 causes direct vasoconstriction by acting on angiotensin 2 receptors, and it also stimulates aldosterone production by the adrenal cortex. Then aldosterone is going to circulate back to the kidneys and facilitate the retention of sodium and water, and that's ultimately going to increase the blood pressure. Next, what substances act on smooth muscle myosin light chain kinase, and how does this affect blood pressure? We said that dihydropyridine calcium channel blockers, epinephrine acting at the beta-2 receptors, and prostaglandin E2 all cause relaxation of vascular smooth muscle, and that leads to vasodilation. And generally, vasodilation leads to a decrease in blood pressure. But remember that when epinephrine activates alpha-1 receptors, it causes vasoconstriction. So the effect of epinephrine is very tissue-specific. In the coronary arteries and the arteries to the skeletal muscle, beta-2 stimulation causes vasodilation to send more blood to the heart, send more blood to the muscles for fight or flight. And at the same time, alpha-1 stimulation in the arteries going to the skin or the GI tract will vasoconstrict and shunt blood away from those tissues. And the last item says, describe the chain of events in which hypotension causes a reflex tachycardia. So low blood pressure results in less stretch of the carotid sinus and the aorta, which causes less stimulation of the parasympathetic afferents, the glossopharyngeal nerve, and the vagus. And then that signal gets transmitted back to the solitary nucleus of the medulla, and that triggers decreased inhibition of sympathetic output. In other words, there's going to be an increase in sympathetic output as well as a decrease of parasympathetic output. And that combination leads to reflex tachycardia. That's it for now. I'll see you next time.
It's time for another 3-question warm-up. Let's get going. First question here, which immunosuppressant matches each of the following statements? First, we have precursor of 6-mercaptopurine. That's going to be azathioprine. Antibody that binds to CD3 on T cells. That's going to be leronlimab. Next, we have antibody that binds IL-2 receptors on activated T cells. That's going to be daclizumab. Inhibits inosine monophosphate dehydrogenase. That's going to be mycophenolate mofetil. Next, we have inhibits calcineurin, leading to the loss of IL-2 production and blockage of T cell differentiation and activation. That's going to be cyclosporin. Also think of tacrolimus and pimcrolimus. And then we have metabolized by xanthine oxidase, therefore allopurinol increases its toxicity. Think of azathioprine and also 6-mercaptopurine. Next question, what are the 5 2s of a Meckel diverticulum? Well, first, you got to think about the size. So the size of the diverticulum, which is around 2 inches. Next, we have the distance from the ileocecal valve is about 2 feet. It occurs in 2% of the population. And a more common presentation is within the first 2 years of life. And then there are 2 possible types of tissue within the diverticulum, pancreatic epithelium and the gastric epithelium. Next question, what is the treatment for Zollinger-Ellison syndrome? So first, just medical management is certainly going to include high-dose PPIs or proton pump inhibitors. Patients with a sporadic gastronoma may actually require surgery to remove that tumor. And then for metastatic gastronoma, we use somatostatin analogs for the symptoms, and then systemic therapy with interferon, chemotherapy, and radiotherapy. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture now.
In some of the earlier videos, I said some pretty mean things about Dr. Lewis. And later I felt bad about it, so I apologized. But he said he would only accept my apology if I let him hit me in the face with what he calls the big red ball of justice. But because emotional stress can actually aid learning and retention, I'm going to let the suspense build for a few minutes. In this video, we're going to talk about hypertension or high blood pressure. You're going to see a lot about hypertension on step 1 because it's so common and it causes so much morbidity and mortality. We're going to talk about the causes of hypertension and some important complications of hypertension in this video, and then we'll talk about treatment in the next video. Hypertension is defined as a blood pressure greater than or equal to 140/90. But you should know that in order to diagnose hypertension, you need elevated blood pressure readings on at least 3 different occasions, the initial visit plus 2 subsequent visits.
So who's at risk of developing hypertension? What are the major risk factors? Well, age is a risk factor. The older you are, the more likely you are to get hypertension. Smoking is an important risk factor, and so is excessive alcohol consumption, excessive sodium consumption, and physical inactivity. Obesity and diabetes are both risk factors, which kind of go hand in hand. Then family history and race are important risk factors as well. Blacks are at a higher risk of hypertension than whites. It's very common in whites too, but even more so in blacks. And for any level of high blood pressure, black patients have worse morbidity and mortality than white patients do.
Roughly 95% of people with hypertension have what we call essential hypertension or primary hypertension, which just means that we can't pin the hypertension on something else like pheochromocytoma or renal artery stenosis and then call it secondary hypertension. The patients just have primary essential hypertension. Now, the other 5% of hypertension is called secondary hypertension, which is hypertension due to some specific identifiable cause. So take a look at the question in your study guide that says, what causes secondary hypertension? The most common cause of secondary hypertension is renal artery stenosis. Other forms of renal disease can also cause secondary hypertension, such as chronic kidney disease or end-stage renal disease. Certain medications can cause hypertension, especially oral contraceptive pills, and also NSAIDs, certain antidepressants, and glucocorticoids. And of course, certain illicit drugs like cocaine or amphetamines can cause hypertension. Several adrenal diseases like hypercortisolism or Cushing syndrome, hyperaldosteronism or Conn syndrome, or pheochromocytoma can do it. And also other endocrine disorders like hypothyroidism or hyperthyroidism and hyperparathyroidism because of the hypercalcemia. Remember, calcium drives smooth muscle contraction and peripheral vasoconstriction, so that's going to cause some hypertension. We talked about coarctation of the aorta and how that can cause high blood pressure in the arms but low blood pressure in the legs. And obstructive sleep apnea can cause secondary hypertension. So think about that if they give you an obese patient with hypertension who has daytime somnolence and snores a lot. Most of the time, hypertension is completely asymptomatic. And because of that, patients tend to ignore their blood pressure for years and years and years until it's way too late because they've already developed some hypertensive heart disease or renal insufficiency. So let's talk about a couple of complications of hypertension, starting with left ventricular hypertrophy, or LVH. LVH is an early form of end organ damage caused by hypertension, which we call hypertensive heart disease. Basically, elevated blood pressure increases the afterload on the left ventricle, which means the left ventricle has to work harder to pump blood against that afterload. Now, what happens when a muscle works harder? It hypertrophies, right? So the wall of the left ventricle gets thicker and thicker, and that's bad for a couple of reasons. First of all, increased thickness of the myocardium causes increased myocardial oxygen demand. There's just more tissue to have to oxygenate. Also, unlike skeletal muscle, thicker myocardium isn't necessarily stronger myocardium. Instead of getting stronger, that left ventricle becomes stiffer and less compliant. So chronic hypertension and LVH cause a stiffened left ventricle. Now, what heart sound would you expect to hear associated with that? An S4 heart sound. Then the third problem with LVH is that as the left ventricle hypertrophies, you aren't increasing the diameter of the heart. Instead, as the muscle hypertrophies, it's actually encroaching upon the luminal diameter of the left ventricle, which means the left ventricle can't hold as much blood during diastole. There's less room for blood, and since the ventricle is stiffer, that ventricle can't relax and accommodate more blood. So LVH is a precursor to left-sided heart failure, and it's also a risk factor for MI. That's why LVH is so important clinically. Another important but much less common complication of hypertension is aortic dissection. Aortic dissection is where you have a tear in the intima of the aorta, the inner layer, and that allows blood to dissect into the wall of the aorta between the layers of the media and form a false lumen. Then when the heart pumps, it's pumping blood into two different sections of the aorta. The two big causes of aortic dissection are hypertension and diseases of the aorta, such as cystic medial necrosis from Marfan syndrome, but hypertension is the most common cause. Dissections usually occur in the ascending aorta, although you can certainly get them anywhere along the aorta. The classic presentation of a dissection is tearing chest pain that radiates through to the back. Anytime you see that presentation, the first thing you have to think of is aortic dissection. Tearing chest pain that radiates to the back. Then the other thing to look for is widening of the mediastinum on the chest x-ray. So anytime you see a wide mediastinum, that's abnormal. You're going to need to get a CT scan or a transesophageal echo to get a better look at what's going on. And the reason that aortic dissection is such a big deal is that it has a very high mortality, somewhere around 75% mortality if you don't recognize it early and treat it. Here we have an image of a chest CT of a patient with an aortic dissection. And look at this large, light-colored oval structure on the patient's left side. Remember, CT scans are always oriented as though the patient is lying on his back and his feet are coming out of the scan toward you. So this is the patient's left side. So this big oval structure is the descending aorta, which appears light-colored because this is a CT with contrast. That IV contrast in the aorta lights up nice and bright. And within the aorta, there's a darker rim forming a small circle. So that's the true lumen of the aorta. The blood is dissected between the layers of the wall of the aorta and created this false lumen, which is the larger portion of the aorta there. We classify aortic dissections using the Stanford classification. So we classify it as either a Stanford type A dissection or a Stanford type B. If the dissection involves any part of the ascending aorta or the aortic arch, that's a Stanford type A dissection, regardless of how far down it goes. You can remember A for ascending or A for arch. And if the dissection is confined entirely to the descending aorta, distal to the takeoff of the left subclavian artery, that's called a Stanford type B dissection. So remember B for below the branches. And the reason why it's important to make that distinction is that type B dissections are managed medically for the most part, but type A dissections are more life-threatening and often require emergency surgery. One other thing to mention briefly is that the drug of choice to lower the blood pressure in a patient with an aortic dissection is a beta blocker. Beta blockers not only reduce the overall arterial pressure, but they also decrease the slope of the rise of the blood pressure. These dissections progress and enlarge not necessarily because the blood pressure is so high, but rather because there's this pounding action of the blood pressure, beat after beat after beat, and that pounding just forces more and more blood into the false lumen and expands the dissection. So if you use a beta blocker to decrease the slope of the rise of the blood pressure, you can slow progression of the dissection. All right, enough suspense. Let's get this over with. Things I do to keep the peace around here. Let's talk about severe hypertension. You'll occasionally hear about hypertensive urgency and hypertensive emergency, which are somewhat controversial terms, but basically they just mean the blood pressure is severely high and potentially dangerous. Hypertensive urgency is usually defined as blood pressure greater than or equal to 180/120 without any evidence of end organ damage. And hypertensive emergency is usually defined as, again, blood pressure greater than or equal to 180 over 120, but with evidence of end organ damage, such as EKG changes, chest pain, headache, vision abnormalities, acute kidney injury, or flash pulmonary edema. So I'd be familiar with those terms and those definitions. Hypertensive urgency does not have end organ damage, yet hypertensive emergency does have evidence of end organ damage. Now, we usually treat this severe hypertension with things like IV nitroprusside or possibly IV labetalol. Because they're short-acting, we can sort of titrate the drip to get the blood pressure just right. And one noteworthy side effect of nitroprusside is cyanide toxicity, so be aware of that. We're going to talk more about antihypertensive drugs in another video, but right now it's time for the end of session quiz. So pause the video, answer those questions, and then we'll go through the answers together. First question, what's the blood pressure cutoff for the diagnosis of hypertension? It's blood pressure greater than or equal to 140 over 90. And you don't have to have elevated systolic and diastolic blood pressure. If you have a blood pressure of 145 over 75, that's still considered hypertension, even though the diastolic pressure is nice and low. Next, what would you most suspect the cause of hypertension to be in a patient with each of the following clinical clues? So paroxysms of increased sympathetic tone causing anxiety, palpitations, and diaphoresis. That's a classic description of a pheochromocytoma, which is releasing catecholamines that raise the blood pressure and cause all these other symptoms. Age of onset between 20 and 50, and without any other information, the most common cause of hypertension in this age group is going to be essential hypertension. An abdominal bruit suggests renal artery stenosis. Blood pressure in the arms is higher than blood pressure in the legs, would be a coarctation of the aorta. Family history of hypertension is more likely to be associated with essential hypertension. Tachycardia, heat intolerance, and diarrhea would be suggestive of hyperthyroidism. Hyperkalemia in the presence of hypertension should make you think about renal insufficiency. Hypokalemia is associated with hyperaldosteronism, but also think about renal artery stenosis, because the body's response to poor renal perfusion is to activate the renin-angiotensin-aldosterone system, and increased aldosterone is going to lead to potassium wasting, and you get some hypokalemia. Central obesity, moon-shaped face, and hirsutism is going to be Cushing syndrome. Young individual with acute onset of tachycardia, think about stimulant abuse here, like cocaine or amphetamines. And then proteinuria is associated with renal disease. Next, what chest x-ray finding is a possible sign for aortic dissection? That's mediastinal widening on chest x-ray. The other things to think about with a wide mediastinum is a ruptured esophagus, which can be catastrophic, and sometimes lymphoma with bulky mediastinal lymphadenopathy. And the last question, what category of blood pressure medications is preferred in the treatment of aortic dissection? It's beta blockers. That's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. Which nerve is affected in each of the following upper extremity symptoms? So first we have scapular winging. So this is the long thoracic nerve innervating the serratus anterior. Loss of forearm pronation, that's going to be the median nerve. Inability to abduct or adduct your fingers, these are the interosseous muscles, which are innervated by the ulnar nerve. Then for abduction of the arm, the initial 10 degrees of abduction is your suprascapular nerve and your supraspinatus muscle, but beyond 10 degrees, that would be the axillary nerve and your deltoid muscle. Paresthesias and pain over digits 1 through 3, that's going to sound like carpal tunnel syndrome, so that's going to be the median nerve. Next, Guillain-Barré syndrome is classically preceded by what infection? So Guillain-Barré syndrome can be preceded by Campylobacter jejuni infection. So I would know Campylobacter jejuni, but also others include things like CMV, Epstein-Barr virus, Mycoplasma pneumoniae, and HIV. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're going to talk about the drugs we use to treat hypertension. We'll discuss the drug classes first, and then we'll talk about some of the finer points of treating hypertension. Now, there are dozens of different drugs that we use to treat hypertension, and we often use them in combination. Many patients with hypertension require more than one drug to control their blood pressure. There are diuretics, which we cover in the renal section. Drugs that act on the adrenergic receptors, like beta blockers and alpha blockers, are covered in Pharm Basics. And centrally acting adrenergic drugs, like clonidine and alpha-methyl-dopa, are also covered in Pharm Basics. The classes of drugs we're going to cover in this video are the ACE inhibitors and ARBs, calcium channel blockers, and then vasodilators like hydralazine and minoxidil and nitrates. Let's start with the ACE inhibitors, which all end in pril, like enalapril, lisinopril, and ramipril. These work by inhibiting angiotensin-converting enzyme, which is part of the renin-angiotensin-aldosterone system. Angiotensin-converting enzyme converts angiotensin-1 into angiotensin-2, so you're inhibiting the production of that potent vasoconstrictor, angiotensin-2. That's one way that ACE inhibitors lower blood pressure because you have less vasoconstriction. The other thing that angiotensin-converting enzyme does is degrade and inactivate bradykinin, which is an important vasodilator. So if you inhibit angiotensin-converting enzyme and bradykinin hangs around longer, that's going to lead to more vasodilation. So ACE inhibitors prevent vasoconstriction and they indirectly promote vasodilation. Now clinically, we use ACE inhibitors to treat hypertension because in addition to lowering blood pressure, they also help prevent some of the left ventricular remodeling that we see with hypertensive heart disease and LV dysfunction. We use ACE inhibitors in CHF for the same reasons, to reduce remodeling and because they reduce mortality in CHF patients. We use ACE inhibitors following an MI to reduce remodeling. And we use them in patients with kidney disease because ACE inhibitors reduce proteinuria. And we use them in diabetics because they reduce the progression of diabetic nephropathy. So be familiar with all these uses of ACE inhibitors. ACE inhibitors are extremely well tolerated overall, but there are a few important side effects that you need to be aware of because lots of patients are taking ACE inhibitors. ACE inhibitors commonly cause a dry, hacking, persistent cough, or sometimes patients just seem to clear their throat a lot. I had a pharmacology professor in med school who was on an ACE inhibitor, and he would clear his throat all the time while he was trying to give a lecture, and it drove us all absolutely nuts. But the mechanism of this cough is worth knowing. We think that the cough is due to those elevated levels of bradykinin. In a second, we're going to see that angiotensin receptor blockers don't increase bradykinin, which is why they don't cause a cough. The second major side effect you need to know with ACE inhibitors is angioedema, which is where you have the swelling of the lips and the tongue and the oral mucosa, basically anywhere from the lips to the larynx. And this can potentially cause airway compromise, and it can be very dangerous, but fortunately it's also very rare. And just like the cough, the angioedema is probably due to elevated bradykinin. ACE inhibitors will also potentially raise the serum potassium a little bit, and they may lead to full-on hyperkalemia. It's not usually a huge problem, but it is something to be familiar with and to monitor for, especially when you first start an ACE inhibitor or whenever you increase the dose. And if you have a patient who's on both an ACE inhibitor and a potassium-sparing diuretic, there's an increased risk of hyperkalemia. ACE inhibitors will also decrease GFR slightly, and that can lead to some mild renal insufficiency and raise the serum creatinine. Again, you want to check labs and monitor this whenever you start an ACE inhibitor. You also need to avoid ACE inhibitors altogether in patients who have renal artery stenosis bilaterally, because they're definitely going to be at risk for renal insufficiency. And then the final toxicity of ACE inhibitors is that they're teratogenic, so they're contraindicated in pregnancy. They're associated with fetal renal dysfunction and oligohydramnios, and also fetal cardiac malformations. Let's talk about the ARBs, or angiotensin receptor blockers. These all end in sartan, like candesartan, losartan, and olmesartan. ARBs inhibit angiotensin receptors, which blocks the vasoconstrictor effect of angiotensin-2, and it also blocks the secretion of aldosterone. ARBs are used just like ACE inhibitors for hypertension, for CHF, for post-MI patients, and patients with kidney disease. And they have most of the same side effects. They're teratogenic, they cause hyperkalemia and renal insufficiency. But make note of this, ARBs do not cause a cough, presumably because they don't increase bradykinin, right? They're not inhibiting angiotensin-converting enzyme, so bradykinin is still being inactivated normally. So ARBs don't cause a cough. But they can cause angioedema, which is a little bit squirrely in my mind because we think the angioedema is also caused by bradykinin. So why should ARBs cause angioedema? Well, they shouldn't, but sometimes they do. So definitely know that. If you have a patient who's on an ACE inhibitor who develops a cough, you can switch to an ARB. But if you have a patient on an ACE inhibitor who develops angioedema, switching to an ARB is still a little bit risky. And then one more drug to mention very briefly is called aliskiren. Now, I don't really have much to say about aliskiren other than it's a renin inhibitor. It's not inhibiting angiotensin-converting enzyme, it's inhibiting renin. And like the ACE inhibitors and ARBs, aliskiren can cause hyperkalemia and some renal insufficiency, and it's contraindicated in pregnancy. But unlike ACE inhibitors and ARBs, aliskiren is not indicated for CHF or MI. It's only indicated for treating hypertension. So it may be a little lower yield for you to know than the ACE inhibitors and the ARBs are. Let's talk about calcium channel blockers. Take a look at your study guide. Calcium channel blockers come in two flavors, the dihydropyridines and the non-dihydropyridines. You can almost think of them as two completely separate classes of drugs. The dihydropyridines are amlodipine, felodipine, nifedipine, and so on. They all end in dipine. These work primarily at the vascular smooth muscle. They have little to no effect at the heart. When we discussed smooth muscle contraction in our video on blood pressure regulation, we saw that dihydropyridines block the voltage-gated calcium channels and prevent calcium from entering the cell, which prevents smooth muscle contraction. So these are vasodilators, and they affect both arteries and veins, but mainly arteries. We use dihydropyridines for hypertension, for angina, and for vasospastic conditions like Prinzmetal angina and Raynaud phenomenon, also esophageal spasm. And sometimes you'll also see them used for migraine prophylaxis or for cluster headaches. For adverse effects, these can cause peripheral edema and flushing from all the vasodilation, and they can cause dizziness and even constipation because you're relaxing the smooth muscle in the gut, so you have less peristalsis and more constipation. And any kind of vasodilator may cause some reflex tachycardia. The other flavor of calcium channel blockers is the non-dihydropyridine calcium channel blockers, which are verapamil and diltiazem. Verapamil works mainly in the conductive tissue of the heart, and it has relatively little effect on the vascular smooth muscle. And then diltiazem, the other non-dihydropyridine, is sort of an intermediate, so it acts on calcium channels in the heart and the vessels. Because these work mainly at the heart, rather than using them primarily for hypertension, we more commonly use them for patients with angina to slow the heart down and decrease oxygen demand. And we also use them to control the heart rate in patients with AFib and other tachycardias. And for adverse effects, the non-dihydropyridines can cause bradycardia, AV block, and cardiac depression. So we try to avoid these in patients with CHF because we don't want to reduce myocardial contractility. You might also see flushing, dizziness, and constipation again. Let's talk about several different kinds of vasodilators, starting with hydralazine. Hydralazine works by increasing cyclic GMP. When we talked about smooth muscle contraction, we said cyclic GMP activates myosin phosphatase, and that dephosphorylates myosin so that the vascular smooth muscle relaxes and the vessel dilates. And hydralazine is going to dilate arterioles more than veins, so it reduces afterload. So remember that hydralazine is an arterial vasodilator. Hydralazine can be used to treat hypertensive urgency and hypertensive emergency. It can also be used to treat hypertension in pregnancy. Now, there are only a handful of blood pressure drugs that are guaranteed safe to use in pregnancy, and you should definitely know them. A student sent us this wonderful mnemonic: hypertensive moms love nifedipine, which stands for hydralazine, methyldopa, labetalol, and nifedipine, or other dihydropyridine calcium channel blockers. Hypertensive moms love nifedipine. And then for side effects, hydralazine is a vasodilator, so it may cause reflex tachycardia. So you might give hydralazine along with a beta blocker to prevent some of this tachycardia. But you don't want to give hydralazine to somebody who has significant coronary disease because that reflex tachycardia will increase myocardial oxygen demand, and that could cause some angina. Hydralazine can also cause some fluid retention, nausea, headache, and drug-induced lupus with antihistamine antibodies. Be sure you know that as well. The mnemonic for the main drugs that you should associate with drug-induced lupus is SHIP, S-H-I-P-P. Sulfonamides, hydralazine, isoniazid, phenytoin, and procainamide. Another arterial vasodilator is minoxidil. Take a look at the study guide. Minoxidil works by opening potassium channels and hyperpolarizing smooth muscle, resulting in relaxation of vascular smooth muscle. Now, why is that? Well, if the cell is hyperpolarized, the calcium channels are going to stay closed. And if calcium can't get into the smooth muscle cell, you're going to have less smooth muscle contraction, right? We use minoxidil to treat severe or difficult to control hypertension. And one interesting side effect of minoxidil is that it causes hair growth or hypertrichosis. So somebody came up with a topical form of minoxidil that you rub into the scalp to treat hair loss and male pattern baldness. That's what Rogaine is, topical minoxidil. So one of the main adverse effects is hypertrichosis. I had a patient who was an elderly woman who had terrible blood pressure problems, and we were so happy because we finally got her blood pressure under control with minoxidil. Then she started growing a little mustache, and we had to stop it. Minoxidil can also cause hypotension, like all blood pressure drugs, and we mentioned that vasodilators can often cause reflex tachycardia. It might also cause some sodium and fluid retention and edema, and so you have to be careful in patients with CHF. A third type of vasodilator is the nitrates, like nitroglycerin and isosorbide dinitrate and nitroprusside, which we sometimes use IV to treat hypertensive emergency. But really, we don't often use nitrates for treating hypertension. Nitrates cause vasodilation by releasing nitric oxide in smooth muscle cells. This causes an increase in cyclic GMP and relaxation of smooth muscle. Nitrates dilate veins more than they dilate arteries, so they tend to reduce preload. Arterial vasodilators like hydralazine reduce afterload, and then ACE inhibitors and ARBs will reduce both afterload and preload, and nitrates mainly reduce preload. So let's say that you have a patient that can't take an ACE inhibitor or an ARB because of hyperkalemia. Well, if you still need to reduce both preload and afterload, like for CHF or an acute MI, you could use a combination of a nitrate plus hydralazine, which is going to do the same thing that an ACE inhibitor or an ARB would. The main clinical use for nitrates is to treat angina and acute pulmonary edema. If you have left-sided heart failure and pulmonary edema, one of the things you can do is give a nitrate to start pooling blood more peripherally. Remember, our mnemonic for treating acute pulmonary edema was no lip, and the N is for nitrates. The side effects of nitrates include reflex tachycardia again, and flushing and headache because of vasodilation. And then what was the unique side effect that we mentioned in conjunction with nitroprusside? Cyanide toxicity. The last thing I want to go over is when to treat hypertension and how to choose the best hypertensive regimen for an individual patient. Now, this is definitely lower yield for step one, but it's worth knowing for your clinical years, and it's certainly fair game for the exam. As you may know, at the end of 2013, the JNC8 released a new set of guidelines for managing hypertension, trying to simplify the treatment of hypertension. For the general population 60 and older, the goal blood pressure is less than 150 over 90. Now that's higher than it was in previous guidelines, but there's no good evidence that lower blood pressure is any safer in this population. For patients under 60, the goal blood pressure is less than 140 over 90. And this includes patients with diabetes and chronic kidney disease, where we used to get more aggressive. Then the third recommendation goes along with that. The goal blood pressure for all adults with diabetes or chronic kidney disease is 140 over 90, even in patients who are 60 and older. So basically, the goal is 140 over 90 for everybody except patients over 60 who do not have diabetes or chronic kidney disease. In those healthy older patients, the goal is 150 over 90. That's pretty simple, even if it is a pretty big departure from previous guidelines.
Now, in 2015, there was a study published called the SPRINT trial. And that study suggested that lower blood pressure goals, less than 120 over 80, resulted in fewer heart attacks and fewer strokes and fewer cardiovascular deaths. But it also resulted in more adverse events, like hypotension and syncope and acute kidney injury. Plus, the SPRINT trial excluded patients with diabetes. So it may be that we'll see new guidelines favoring lower blood pressure goals eventually, but for now, the JNC8 guidelines are still in effect. Now, JNC8 also gave recommendations on which antihypertensive medications you should choose. Take a look at the study guide. In patients with chronic kidney disease, your first-line treatment for hypertension is going to be an ACE inhibitor or an ARB. We know that these are renal protective drugs in general, so we're going to start with those classes. In blacks, specifically blacks without chronic kidney disease, treatment should start with a thiazide diuretic or a calcium channel blocker. These will improve cardiovascular outcomes more than ACE inhibitors in blacks, and that's why they get preferred status. Then in non-blacks without chronic kidney disease, you can still use a thiazide or a calcium channel blocker, or you can start with an ACE inhibitor or an ARB. So you have 4 choices for initial therapy in the general non-black population. Now, there might be reasons that you would want to start another class of medication. So take a look at the next table. Patients with a history of CHF need to be on an ACE inhibitor or an ARB, and a beta blocker, and an aldosterone antagonist like spironolactone. So in a patient with both hypertension and CHF, you might start with one of these rather than with a calcium channel blocker. In fact, since calcium channel blockers can cause fluid retention and edema, they may not be the best initial therapy for patients with both hypertension and CHF. And remember, you have to use beta blockers very, very cautiously in CHF patients, and they're contraindicated in CHF patients with acute decompensated CHF. If your patient has hypertension plus diabetes, you might reach for an ACE inhibitor or an ARB first line, because ACE inhibitors and ARBs will protect against diabetic nephropathy, and they reduce the progression of proteinuria. And then remember that beta blockers can raise the blood sugar a little bit, and they can mask the adrenergic symptoms of hypoglycemia. So you need to use beta blockers very cautiously. They're not absolutely contraindicated in diabetics, you just have to use caution. In post-MI patients, thiazides, beta blockers, ACE inhibitors, and ARBs are all going to reduce morbidity. And then the calcium channel blockers and nitrates might be added if you need to relieve ongoing anginal pain. In patients with AFib, we sometimes need to start with a beta blocker or with diltiazem or verapamil to control the heart rate, and those might also help to control the blood pressure. In patients with bradycardia, you'd want to avoid those same drugs because they tend to slow down the heart. Patients with BPH or benign prostatic hyperplasia can benefit from alpha blockers because that's going to lower the blood pressure and treat the symptoms of urinary retention. We've already discussed the drugs preferred in pregnancy. What was that mnemonic? Hypertensive moms love nifedipine. And remember, no ACE inhibitors or ARBs. They're contraindicated in pregnancy. Calcium channel blockers and beta blockers can be used to prevent migraines. So if you have a patient with a history of migraines who now has hypertension, that might be a good reason to start with one of these drugs. And then essential tremor can sometimes be treated with propranolol. So that might be a good choice in those patients.
Now it's time for the end of session quiz. So answer those questions, then we'll go through them together. First question, which antihypertensive class or drug fits each of the following side effects? Hypertrichosis is a side effect of minoxidil. Cyanide toxicity can be seen with sodium nitroprusside. Reflex tachycardia would be any type of vasodilator like nitrates, hydralazine, and dihydropyridines. Cough, that's going to be the ACE inhibitors. Possible development of drug-induced lupus. Remember, there were 5 drugs in that SHIP mnemonic, but the one that was antihypertensive was hydralazine. And possible angioedema. This is the ACE inhibitors again, and maybe also the ARBs. Remember, that's due to elevated bradykinin. Next, which antihypertensives are particularly beneficial to heart failure patients? Well, the drugs that are proven to improve survival in CHF patients are ACE inhibitors, ARBs, aldosterone antagonists, and the beta blockers carvedilol, metoprolol, and bisoprolol. And then diuretics, especially loop diuretics, are also used in CHF for symptomatic relief, even though there's no clear survival benefit. And the last question, which antihypertensives are safe to use in pregnancy? One more time, our mnemonic was hypertensive moms love nifedipine. Hydralazine, methyldopa, labetalol, and nifedipine. That's it for the antihypertensive drugs. I'll see you next time.
Welcome back. Let's go over the answers to the warm-up review. First question, where do neurons of the lateral corticospinal tract synapse prior to exiting the spinal cord to affect movement? At the cell body of the anterior horn. Next question, what drugs and endogenous hormones regulate the secretion of gastric acid? Let's start with the hormones. Several hormones and chemicals promote gastric acid secretion, including histamine, acetylcholine from the vagus nerve, as well as gastrin. And then several other hormones and transmitters inhibit gastric acid secretion, including prostaglandins, somatostatin, secretin, and GIP, or gastric inhibitory peptide. And then the drugs that regulate secretion are the PPIs, the H2 blockers, and the anti-muscarinic drugs such as atropine. Now let's move on to the lecture.
In this video, we're going to discuss atherosclerosis, and we'll start a discussion of atherosclerotic cardiovascular disease that's going to span several videos, including things like acute coronary syndromes and myocardial infarction, which are covered elsewhere. But in this video, we're going to review some definitions and pathophysiology. So let's start with arteriosclerosis, which is a generic umbrella term for hardening or stiffening of the arteries, in which the arterial wall becomes fibrotic and thickened and less elastic. Sclerosis means scarring, so this is scarring and thickening of the arteries. There are several different types of arteriosclerosis. There's something called medial calcific sclerosis, or Monckeberg arteriosclerosis, which is fairly uncommon. This is a disease of the elderly population that causes calcification of the media of the arteries, hence the name medial calcific sclerosis. So the arteries become stiff and non-compliant, especially in the extremities. But the intima is not involved, so there's no stenosis and no obstruction of blood flow. This is usually fairly benign. The next type is arteriolosclerosis, which is much more common. So this affects arterioles and small arteries. And you can either see hyaline thickening of the vessel walls or hyperplasia of the vascular smooth muscle cells that gives the arterioles an onion skin appearance under the microscope. And both of these can be secondary to hypertension, which is why hypertension is such a bad disease. It causes small vessel disease long before there are any symptoms. So even without significant hyperlipidemia, patients may have arteriolosclerosis. And then the most common form of arteriosclerosis is atherosclerosis, which is the classic disease where you get the fibrous cholesterol plaques and atheromas that form in the intima of the large and medium-sized arteries. So don't confuse arteriosclerosis and atherosclerosis. They're not exactly the same thing. Arteriosclerosis is a general term describing hardening of the arteries. Atherosclerosis is just one type of arteriosclerosis, but it is the most common type. So what are the risk factors that increase your chances of developing atherosclerosis? Well, it's things like hypertension, hyperlipidemia, especially elevated LDL cholesterol, diabetes, and of course, smoking. And don't forget things like family history, advancing age, and even sex. Atherosclerosis is more common in men and postmenopausal women than it is in premenopausal women. So let's look in the study guide and review the pathogenesis of atherosclerosis. There's a progression of events that leads to atherosclerosis. It all starts with endothelial dysfunction. The endothelium is the inner lining of the arterial wall, And over time, those traditional risk factors like smoking, diabetes, and hypertension cause damage to the endothelial cells, which leads to increased vascular permeability, leukocyte adhesion, and thrombosis. Next, you get accumulation of lipoproteins. That endothelial dysfunction allows lipids, especially LDL, to begin to accumulate in the intima of the vessel and become oxidized. The next step is monocyte adhesion to the endothelium. So monocytes migrate into the intima and then transform into macrophages that phagocytose the LDL. And we call those macrophages full of LDL foam cells. The next step is labeled as factor release. So inflammation plays a huge role in the pathogenesis of atherosclerosis. So activated platelets and macrophages are releasing a lot of inflammatory mediators and cytokines. Atherosclerosis and inflammation kind of go hand in hand. And as a result of this inflammation, we see a proliferation of smooth muscle cells and a deposition of extracellular matrix composed of elastin and collagen. Smooth muscle cells are normally found in the media of arteries, but now we see the migration of these smooth muscle cells into the intima. And there's continued accumulation of lipid both extracellularly and also intracellularly within the macrophages and smooth muscle cells. And all this smooth muscle proliferation and extracellular matrix and lipid accumulation results in a bulging atherosclerotic plaque that can protrude into the lumen of the vessel and cause stenosis and narrowing and reduced blood flow. And if this plaque ruptures, that's going to trigger platelet aggregation and thrombosis, which results in an acute ischemic event like an MI or a stroke or an ischemic limb. We said that atherosclerosis affects large and medium-sized arteries, but it doesn't affect all arteries equally. For instance, the abdominal aorta is one of the most common sites of atherosclerosis. But because it's such a large diameter vessel, it's uncommon to get stenosis or narrowing of the aorta that's bad enough to impair blood flow. What we do see in the abdominal aorta is an abdominal aortic aneurysm, also known as a AAA. AAAs are caused by atherosclerotic plaque that compresses the underlying media, and this compromises diffusion of both nutrients and waste products. And over time, this results in degeneration and necrosis of the media, leading to weakness in the aortic arterial wall, and that results in a focal dilation or bulge in the aorta, which is the aneurysm. Now, AAAs are more common in men over 50 and especially in smokers. AAA can present as a pulsating mass in the abdomen if the patient's thin. In overweight or obese patients, you might not be able to feel it at all. The bad news is that a AAA can rupture and hemorrhage into the abdomen, which can be fatal very rapidly. It can also cause embolization of pieces of atheroma, or possibly obstruction of a branch vessel and impingement on an adjacent structure, such as a ureter. You can diagnose a AAA with an ultrasound, and then we monitor the AAA with serial ultrasounds every 6 months. Now, when the AAA gets to 5.5 centimeters in diameter in men, or 5 centimeters in women, that's when you repair these surgically. You'd also repair these if they're enlarging rapidly. So if you see an increase of 0.5 centimeters within 6 months, or 1 centimeter within 1 year, then you're going to send that patient for surgical repair. Another important site of atherosclerotic disease is the coronary arteries. So let's review the anatomy of the coronary arteries. Being able to identify coronary arteries on an angiogram is about a 3-star topic. There are 2 coronary arteries that come off the aorta, the left main coronary artery and the right coronary artery, or the RCA. So it's the left main and the RCA. The left main gives rise to the left anterior descending branch and the circumflex branch, so the LAD and the circ. The LAD is the artery that's most commonly affected by an MI. You can get an MI from occluding any of the coronary arteries, but the LAD is the most common one. The left anterior descending artery supplies the anterior wall of the left ventricle, and also the anterior portion of the interventricular septum. So if the LAD is occluded, that's an anterior wall MI. Then the other big branch off the left main is the circumflex artery, which makes a hard left and wraps around the heart to supply the lateral wall of the left ventricle. So occlusion of the circumflex artery will cause a lateral wall MI. Then the main branch of the RCA to know about is the posterior descending artery, or the PDA. So the posterior descending artery goes down the back of the heart. It descends posteriorly, and it supplies the inferior wall of the left ventricle. So if the PDA is occluded, that's an inferior wall MI. Now, around 70 to 85% of people have the PDA coming from the right coronary artery. And we call this a right dominant heart. Around 10% of people have a PDA that comes off the circumflex, and we call that a left dominant heart, since the circumflex is part of the left coronary system. There's also something called a codominant heart, where the PDA is supplied by both the RCA and the circ, and that's also around 10%. The exact numbers aren't that important, but the vast majority of people have right dominant hearts. It's also worth mentioning that the sinoatrial node and the atrioventricular node are usually supplied by a branch from the right coronary artery. So an RCA infarct can affect the SA node and cause bradycardia, or it can affect the AV node and cause an AV node block. You should also remember that the coronary arteries fill with blood during diastole, whereas the systemic arteries fill during systole. Remember, the coronary arteries come off the proximal aorta, just beyond the aortic valve. So when the aortic valve is open during systole, the valve leaflets kind of open up and shut off those coronary arteries in a sense. So the coronaries fill with blood when the aortic valve is closed during diastole. Now let's talk about ischemic heart disease. Ischemic heart disease occurs when myocardial oxygen demand is greater than the myocardial oxygen supply, and it's most commonly caused by atherosclerosis. And when this occurs, it typically causes chest pain that we call angina. The typical symptoms of angina include chest pain, which is normally retrosternal chest pain, meaning it occurs just posterior to the sternum. And this can be described as pain, but sometimes people will say it isn't really a pain, it's more like a pressure in the chest or a sensation of tightness or heaviness. This pain can radiate to the neck, the jaw, or the left shoulder, and it might be associated with shortness of breath, diaphoresis or sweating, or simply some fatigue, especially in women. Female patients commonly have atypical angina symptoms rather than the classic retrosternal chest pressure radiating to the jaw. So you have to have a high level of suspicion. Angina tends to occur when there's coronary artery stenosis of at least 75%. The coronaries can dilate as needed in order to provide additional myocardial perfusion during times of increased oxygen demand, like exercise or tachycardia from fear or stress. But once the coronary arteries become narrowed more than 75%, you may start to see some problems. There are also different types of angina, or different patterns of anginal pain. Stable angina is the most common type. Stable angina is predictable. Every time the patient climbs 3 flights of stairs, or walks more than 2 blocks, or pushes the lawnmower more than 15 minutes, he starts having chest pain. So it's a stable, predictable pattern brought on by a certain level of activity. The other predictable thing is that this chest pain resolves with rest. And you may see some ECG changes with stable angina, such as ST segment depression or elevation. Next is unstable angina. So unstable angina is the same pain presentation, but now the pain is increased in frequency or it's become unpredictable. For instance, if the patient normally has angina after climbing 3 flights of stairs, but now he's having that same anginal chest pain after climbing only 1 flight, that's now considered unstable angina. It's also considered unstable angina if the pain occurs at rest, or if there's an increase in the duration or severity of the pain compared to previous episodes of chest pain. An unstable angina is generally thought to be due to transient thrombosis of a narrowing coronary artery. So that atherosclerotic plaque ruptures and it thromboses, but not bad enough to cause complete occlusion and infarction. So there's some ischemia, but there's no infarction. But you can still see some ECG changes. Then another type of angina is called Prinzmetal angina or variant angina. Now, Prinzmetal angina is not due to atherosclerotic plaques. Prinzmetal angina is due to coronary artery vasospasm. So the coronaries spasm, they narrow down, and that causes some myocardial ischemia. Because this is due to coronary artery spasm, the pain is not brought on by exertion, but rather it occurs at rest. It's generally more common in younger individuals because there's really no atherosclerosis to speak of. And again, you can see ECG changes such as ST segment elevation. Now, how do we treat Prinzmetal angina? Well, we typically use dihydropyridine calcium channel blockers like nifedipine. These drugs are going to relax the coronary arteries and block that spasm. And then, of course, myocardial infarction is the most severe form of ischemic heart disease, but we're going to cover that in another video. So we've talked about ischemia and angina due to atherosclerosis, and we've alluded to myocardial infarction as a cause of chest pain, but not all chest pain is due to myocardial ischemia. The trick is figuring out which patients have chest pain from heart disease and which ones have chest pain from something else. So knowing the differential for chest pain can be really important clinically. There are 5 big things that you need to consider and look for because these are potentially life-threatening. And we've seen a couple of them already. One mnemonic for the 5 deadly causes of acute chest pain is if you're dumped, you're heartbroken. So the D in dumped is for aortic dissection, which is where there's a small tear in the intima of the thoracic aorta and then blood forces its way into that tear and then between the layers of the aorta. And this typically presents as a tearing chest pain that radiates through to the back, and you might see some widening of the mediastinum on chest x-ray. The U is for unstable angina, which we just covered. The M is for myocardial infarction. And then there are a couple of these deadly causes of chest pain that are associated with pulmonary pathology. The P is for pulmonary embolism, And the T is for tension pneumothorax, which is where there's a collapsed lung with a flap that acts like a one-way valve, so that when the patient breathes in, air escapes the lung and goes into the pleural cavity, and that kind of builds up pressure inside the pleural cavity. This is going to shift the mediastinum away from the pneumothorax, and that patient may have hypotension and hemodynamic collapse. But thankfully, most patients with acute chest pain will not have one of these life-threatening diagnoses. While in practice, it's often tricky to make the correct diagnosis based on just very quick history, on your exam, they're generally going to give you some classic clues to point you in the right direction. So let's take a look at some of these classic scenarios. ST segment elevation only during brief episodes of chest pain without exertion. This is a classic scenario of Prinzmetal angina. The patient can point to a specific painful spot on the chest with one finger. It's most likely musculoskeletal chest pain, such as costochondritis, or maybe a pulled chest wall muscle. Costochondritis is basically inflammation where the ribs insert into the sternum, usually in the upper sternum at the junction with the second rib. That's a very common cause of chest pain, and we treat that with NSAIDs. The next bullet says chest wall tenderness on palpation. This is another classic feature of musculoskeletal chest pain. Cardiac pain typically won't cause chest wall tenderness, but musculoskeletal pathology can. Rapid onset of sharp or tearing chest pain that radiates to the scapula is an aortic dissection. Rapid onset of sharp pain in a 20-year-old that's associated with dyspnea. This is a classic presentation of a spontaneous pneumothorax. It's a little different than a tension pneumothorax. But this can be very painful and causes some shortness of breath, but you don't get a buildup of pressure that causes that shift of the mediastinum. The next one is occurs after heavy meals and improves with antacids. That's classically GERD, gastroesophageal reflux disease, but it could also be esophageal spasm. Spasm of the esophagus is tricky because it isn't always associated with meals. And if you give the patient nitroglycerin, like you would for a suspected MI or angina, nitroglycerin is a smooth muscle relaxer, so it's also going to relieve the pain of esophageal spasm. So just because the patient's chest pain got better with nitroglycerin, that doesn't prove that this is true cardiac chest pain. The next one says sharp chest pain lasting hours to days that's somewhat relieved by sitting up and leaning forward. That's classic for pericarditis. Pain that's made worse by deep breathing and or motion. That should make you think of pleurisy, inflammation of the pleura, such as from pneumonia. Or it could make you think of musculoskeletal pain because deep breathing expands the chest wall and those inflamed muscles and ribs can hurt. And then chest pain in a dermatomal distribution would be herpes zoster or shingles. And usually you'll see a rash with herpes zoster in that dermatomal distribution. The rash consists of grouped vesicles or small blisters on a red base. And with zoster, pain is a common presenting symptom even before the rash develops, sometimes days before the rash develops. And then finally, the most common cause of non-cardiac chest pain is probably musculoskeletal chest pain. GERD is certainly common too, but musculoskeletal pain is about twice as common. Now it's time for the end of session quiz. So pause the video and answer those questions, then restart the video and we'll go over the answers together. First question. A 68-year-old man has an abdominal ultrasound to check on the status of his known abdominal aortic aneurysm. His last ultrasound 6 months ago showed a maximum dilation of 4.5 centimeters. This most recent ultrasound reveals that the AAA has enlarged to 5.1 centimeters. He's asymptomatic, so what's the most appropriate next step in the management of this patient? Well, the absolute cutoff for elective repair of an asymptomatic AAA in men is 5.5 centimeters, so he's not there yet. But this patient's aneurysm increased in diameter by 0.6 centimeters within a 6-month period. So any increase of greater than 0.5 centimeters in 6 months or 1 centimeter over the course of a year would be an indication for repair. So the next step is surgical repair of this AAA. Next, a patient with poorly managed hypertension has acute, sharp substernal pain that radiates to the back and progresses over a few hours, followed by death within a few hours. So what's the most likely diagnosis? Well, this is an aortic dissection, which incidentally is not the same as an abdominal aortic aneurysm. Next, what's the most likely cause of chest pain in each of the following scenarios? So acute onset dyspnea, tachycardia, and confusion in a hospitalized patient is a pulmonary embolus. This can present with or without chest pain. Rapid onset of sharp chest pain in a 20-year-old and associated with dyspnea is a spontaneous pneumothorax. Chest pain that began 1 day after starting an intensive new exercise program would be musculoskeletal chest pain. ST segment elevation that occurs only during brief episodes of chest pain is a classic scenario of Prinzmetal angina. And then sharp pain lasting hours to days and it's somewhat relieved by sitting forward, is pericarditis. And chest wall tenderness on palpation is musculoskeletal chest pain. And that's it for now. I'll see you next time.
Oh no, it's...
That's right. I'm coronary heart disease. The leading cause of death in the United States.
But haven't you been on a steady decline since the 1960s due to advances in drugs for hyperlipidemia?
You silly human. I still kill 50% of people over the age of 65. My risk factors include smoking, hypertension, low HDL, and family history of premature CHD and age over 45.
No! What can I do? I know I will take a statin to decrease LDL, improve coronary endothelial function, inhibit platelet thrombus formation, and for its anti-inflammatory properties.
Dude, it was horrible acting. Gosh, you're not even trying.
It doesn't matter if my acting sucked, as long as we retain the information.
I am stomping and roaring my butt off over here to get ready for this exam, and you don't even care. You know what? I can't take this. I'm going in my trailer.
Well, someone's a diva.
This is the 3-question warm-up for Cardiovascular 18. The first question says, label the following diagram of lung volumes. A is the inspiratory reserve volume, B is the tidal volume, C is the expiratory reserve volume, D is the residual volume, E is the inspiratory capacity, F is the vital capacity, G is the functional reserve capacity, and H is the total lung capacity. Next, what substance is important for relaxing the lower esophageal sphincter? That's nitric oxide. And the last one, what's the most common type of TE fistula? So the most common type is where you have a blind upper esophagus, and then the lower esophageal segment is attached to the trachea, and that's seen in about 85% of tracheoesophageal fistulas. All right, let's get to the lecture.
Hello everyone and welcome to our Step 1 video on anti-anginal therapy and lipid-lowering agents. Let's get going. So we're going to talk about some of the ways to relieve anginal symptoms with anti-anginal therapy. Now don't get confused, this video is not about treating a myocardial infarction. We'll cover that in the MI video. This lecture is going to cover some of the physiology and the theory behind angina, and then in the next couple lectures we'll hit the details on how to treat that MI. So what is angina pectoris? So this is chest pain due to ischemia of the heart muscle. Now it is usually due to obstruction or spasm of the coronary arteries. Atherosclerosis is the primary cause of the obstruction that leads to that oxygen deprivation. Now in general, angina worsens gradually. Now patients have little to no pain during rest, and symptoms only arise when the heart requires more oxygen, say during exertion. Now we call this stable angina. However, as atherosclerosis worsens, angina becomes more severe or occurs during rest, and this is termed unstable angina. Now unstable angina is concerning because it is an indication of an impending myocardial infarction. So the goal in treating angina is to reduce myocardial oxygen demand, and there are several contributing factors that increase the oxygen demand of the heart. These include things like preload, blood pressure, contractility, ejection time, and heart rate. So, in order to get a handle on this concept, let's compare two different drug categories, nitrates and beta blockers. So these two types of drugs are some of the mainstays in anti-anginal treatment. One affects preload, one affects heart rate and contractility primarily. So you'll also see that as you combine these drugs, the combination is going to be more effective than either one alone. So let's start with end-diastolic volume. So in the video on the cardiac cycle, we discovered that end-diastolic volume is the same thing as preload. So how much blood is getting back to the heart. And most of the time, the cardiac output is going to increase as the preload increases as well. So this will certainly increase the work of the heart. Nitrates decrease preload, so they are relaxing the venous system and less blood is getting to the heart. Beta blockers don't affect the preload that much, and when you combine the two, you'll see an overall decrease in preload. Now let's move on to blood pressure. Blood pressure can be a good equivalent of afterload. Blood pressure can be reduced by both nitrates and beta blockers, and the effect of the combination is going to be an even greater reduction in blood pressure. Now, which drug would you use in order to decrease contractility? Well, one of the primary actions of beta blockers is to decrease contractility. Conversely, though, nitrates aren't going to affect contractility directly, but there can be a slight increase. That seems unusual. Well, the increase in contractility could occur as a reaction to the drop in blood pressure. Your body senses a drop in blood pressure and it compensates by beating a little bit harder. Now, if you combine the two, then you get actually very little change in contractility overall. They kind of balance each other out. Now we see almost the same scenario with heart rate. Beta blockers are going to decrease the heart rate, and then the nitrates tend to increase the heart rate again because of that reflex to that lower blood pressure. But because the beta blocker is a bit stronger at lowering the heart rate, we do see a net decrease in heart rate overall if you combine the two meds together. What about ejection time? Nitrates are going to decrease ejection time. Beta blockers will increase it. The combo result is going to be about no effect. Now, the most importantly part of all this is actually myocardial oxygen consumption or demand. And of course, they both work to decrease the oxygen demand, but they work very differently. Nitrates are working on preload, beta blockers again are working on that heart rate, contractility, and afterload. And the combination of the two is going to overall decrease that oxygen demand more than either one could do it alone. All right, so now let's move on to another anti-anginal drug I want to briefly mention here is ranolazine. This works by inhibiting the late phase sodium current, which will reduce diastolic wall tension, and it's going to decrease the work of the heart and decrease oxygen demand. And though it's reducing that diastolic wall tension, it actually does not affect heart rate or heart contractility. We use ranolazine when a patient has refractory angina despite being on other treatments. Side effects are going to include headache, nausea, constipation, dizziness, and prolongation of the QT interval. All right, so now let's switch gears. Let's talk about some lipid-lowering agents. So we have a biochem lecture that deals with all of the details about lipid absorption and metabolism. This video is really only going to talk about three major categories of lipids: the LDL, the HDL, and the triglycerides. Now, the low-density lipoproteins are most closely associated with atherosclerosis. The higher the LDL, the more likely a patient is going to develop atherosclerosis and subsequently coronary artery disease. So how do we treat high LDL? Well, the first set of drugs are the HMG-CoA reductase inhibitors. So these are the statins. So they include things like lovastatin, pravastatin, simvastatin, atorvastatin, rosuvastatin. There's even several others. HMG-CoA reductase is the rate-controlling enzyme that controls cholesterol synthesis in the human body. So these medications inhibit the body's ability to produce de novo cholesterol. Now, a secondary mechanism is that when cells are unable to produce cholesterol, they then increase the number of cell surface LDL receptors, which will then internalize circulating LDLs. This results in an overall decrease in plasma LDL again. Now, they have some effects on raising HDL and lowering triglycerides as well. Now, what about the adverse effects though? Now, most patients won't have any problems with the statins, but one side effect is hepatotoxicity. This occurs much less often than we originally thought. In years past, we were checking LFTs every 3 to 6 months. This is no longer necessary. And you need to check LFTs before initiating the statin, but after that, there's really no need for further monitoring. Statins can also cause problems with muscles. So this can be very mild myalgias, but it can also progress to more significant myositis, and then even progressing to rhabdomyolysis and renal involvement. So if a patient complains of muscle pain while on a statin, you have to stop the medication, and then the symptoms generally resolve. If there's question whether or not someone is having actual muscle breakdown, then you can measure serum creatinine phosphokinase, CPK, which is an indicator of muscle damage. Now let's move on to the bile acid binding resins. These are not used that commonly anymore. They include drugs like cholestyramine, cholestyramine, and cholesevelam. These prevent intestinal reabsorption of bile acids. Now, unfortunately, patients don't like them very much. They taste bad and they cause GI problems. They can also cause decreased absorption of fat-soluble vitamins. Now, rarely they can lead to the development of cholesterol gallstones. Another drug that can decrease LDL is the cholesterol absorption blocker ezetimibe. Ezetimibe is actually pretty decent at lowering LDL. Ezetimibe prevents cholesterol reabsorption at the small intestine brush border. Now, the side effects include increases in LFTs. If you're using this with a statin, you might have a combined effect and increase the risk of LFT elevation even further. Now, you will see some diarrhea with this medication as well. I tend to use this med more often when I have a patient who doesn't tolerate the statins. Next, let's talk about niacin. Niacin is known for its effect on HDL. HDL is considered the good cholesterol. It acts to remove fats and cholesterol from cells, including arteries, and it's going to transport it back to the liver. So patients with high HDL tend to have fewer problems with cardiovascular diseases. Now, niacin is going to raise HDL better than anything else that we have right now. Niacin will also decrease LDL, but not as much as the statins. Now, currently there are no ACC or AHA recommendations for treating isolated low HDL. Plus, there are certain issues with the safety profile and side effects of niacin. So physicians are not treating low HDL with niacin as much as they used to. But when niacin is used, the biggest problem with the drug is its side effect of flushing of the face. Patients may develop a rash and have itching or pruritus as well. Now, this can happen in about 40 to 45% of patients who take niacin, so it's very, very common. You can decrease the flushing by giving aspirin about 30 minutes before the niacin. Also, you can reduce flushing by just sticking with the drug. After long-term use of niacin, the flushing will abate a little bit and not be so problematic. You should also tell them to avoid other things that can cause flushing, things like alcohol, hot beverages, after taking their niacin. Now, the other category of lipid that we often measure in the blood is triglycerides. High triglyceride levels are associated with atherosclerosis and heart disease, but they are not as important as LDL. The LDL is still the strongest predictor of heart disease. Now, very elevated triglyceride levels will increase the risk of pancreatitis. So, how do we decrease triglycerides? Well, many of our previous medications will decrease triglycerides, but not as much as the fibrates or fibrates. Now, gemfibrozil and fenofibrate are the most commonly used. The main effect of this is lowering triglycerides. The adverse effects, though, are pretty similar to statins. You can get some myositis, myalgias, even some hepatotoxicity. Because of this, it's potentially dangerous to use a fibrate in combination with a statin. If you have a patient who comes in with both elevated LDL and elevated triglycerides, you might want to give them both, but it's a little tricky. Unfortunately, that combined effect is going to increase that risk of myositis. These drugs can also increase the risk of cholesterol gallstones as well. Now, one more group are the omega-3 fatty acids, fish oil. Not all types of fish oil, not cod liver oil, but salmon, halibut, cold water ocean fish are very high in the omega-3 fatty acids. Flaxseed oil also has omega-3s, so the main effect of the omega-3 fatty acids is lowering triglycerides. It's not as strong as the fibrates. Not a whole lot of side effects except for the fishy taste and sometimes a fishy odor or some heartburn with the omega-3s. All right, that's it for the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, which lipid-lowering agent matches the following description? So first we have the lipid-lowering agent with side effect of facial flushing. That's going to be niacin. Side effect of elevated LFTs and myositis. So think of primarily both the statins and the fibrates. Side effect of GI discomfort and bad taste. Think of those bile acid binding resins. Best effect on triglycerides and VLDL, that's going to be your fibrates. Less effective are the omega-3 fatty acids. And best effect on LDL and cholesterol, that's your good old-fashioned statins. Next, what is the effect of nitrates on preload, heart rate, and myocardial oxygen demand? So nitrates are primarily venodilators, which will result in decrease in the preload. Because of the lowered blood pressure effects of the nitrates, we see a potential increase in heart rate. And finally, because of the lower preload, the myocardial oxygen demand is going to be decreased. All right, guys, that's the end of our video. I hope you learned something. I'll see you next time.
All right, let's go through the answers to your warm-up review. What is the classic presentation of congenital pyloric stenosis? Congenital pyloric stenosis occurs in an infant, usually 2 to 6 weeks of age, with non-bilious projectile vomiting, and then on exam, you classically will feel a palpable mass in the right upper quadrant described as feeling like an olive. And if the vomiting goes on for too long, the child can develop hypochloremic metabolic alkalosis with hypokalemia. Next question. For what type of information Is each of the following thalamic nuclei a relay station? The ventral posterior lateral nucleus relays somatosensory information from the body. The lateral geniculate nucleus relays information from your visual retina to your occipital cortex. The ventral posterior medial nuclei relays somatosensory information from the face via the trigeminothalamic tract to the medial lemniscus. And the ventral anterior nucleus relays information from the motor basal ganglia to the cortex. Next question, how does fetal hemoglobin differ from adult hemoglobin? Adult hemoglobin has higher affinity for 2,3-DPG than fetal hemoglobin does, and since fetal hemoglobin has a lower affinity for 2,3-DPG, it also has a higher affinity for oxygen than adult hemoglobin. All right, that's it for your warm-up. Let's move on to the lecture.
In this video and the next one, we're going to continue our discussion of atherosclerotic cardiovascular disease by reviewing myocardial infarction, or MI, also known as heart attacks. Or sometimes you'll hear lay people talk about having a massive coronary. There are a lot of imprecise terms people use. Sometimes people think a cardiac arrest is the same thing as a heart attack. So sometimes you're going to have to dig a little deeper and find out what the patient really means. But in this video, we're going to talk about the presentation of an MI and how we make the diagnosis, and then we'll talk about complications and treatment in the next video. So what's the difference between angina and myocardial infarction? I want you to remember that myocardial infarction is myocardial ischemia that results in myocardial injury or necrosis. Now, we said in a previous video that when there's an atherosclerotic plaque in a coronary artery and that plaque ruptures and then transiently thromboses, that can cause some myocardial ischemia that we call unstable angina. But in unstable angina, there is no myocardial necrosis. But in an MI, the coronary thrombosis lasts long enough to cause injury and necrosis of the myocardium. The most common coronary artery involved in an MI is the left anterior descending artery, or the LAD. And which wall of the heart do we say is perfused by the LAD? The anterior wall. So the most common type of MI is an anterior wall MI. The second most common artery involved is the right coronary artery, and the circumflex is the third most common. Now, because MI and unstable angina are both caused by coronary thrombosis and ischemia, the presentation can be identical. The patient might present with chest pain. It might radiate to the neck or the jaw or to the left arm. The patient might present with diaphoresis or sweating, tachycardia, dyspnea, and nausea. So you can't really distinguish between unstable angina and an MI by history or even on physical exam. Now, some types of MI will show characteristic ECG changes, which we're going to look at later. But the most important diagnostic finding is elevated cardiac enzymes. So you won't see elevated enzymes in a patient with angina. So make sure you know that distinction. Next, let's talk about what happens physically to the heart during an MI and how that evolves over time. When myocardial ischemia occurs for less than 20 to 40 minutes, that's potentially reversible. Those myocardial cells haven't started to necrose yet. But after that 20 to 40 minute marker, then you're going to have irreversible damage. And the longer the ischemia persists, the more tissue is damaged. That's why in the ER, chest pain is worked up very quickly. Time is myocardium. Take a look at the table in your study guide and let's think through what's going on over time, both grossly and microscopically. For the first 4 hours or so, there are no gross changes and no microscopic changes. But during that time, there's an increased risk of arrhythmia. Ventricular arrhythmias are a major reason that people suddenly drop dead from an acute MI. 4 to 12 hours after the MI, grossly, you're going to start to see some dark mottling of the heart. Well, you don't actually see it unless you do an autopsy. Then microscopically, you begin to see some early necrosis and hemorrhage. And again, arrhythmia is the most feared complication during this time period. At 12 to 24 hours, we still see dark mottling grossly, but microscopically we see contraction bands that may indicate reperfusion injury. You can also see coagulative necrosis, and neutrophils are beginning to migrate into the infarcted tissue to clean up the mess where necrotic cells lyse and start spilling all their contents. Neutrophils are recruited to come phagocytose the cellular debris. And again, we're still primarily worried about arrhythmia as a complication. At 1 to 3 days post-MI, grossly there's still some dark mottling and you're beginning to see hyperemia. That means there's some redness at the site of the infarct. Microscopically, there's coagulation necrosis, extensive inflammation, and ongoing neutrophil infiltration. And our biggest risk is still arrhythmia. At 3 to 14 days, you start to see yellow-tan softening of the infarcted myocardium grossly. You might think of an MI as being a wound of the heart muscle. There's not a lot of difference. Early on, there's a lot of redness and swelling around the damaged area, and then as that starts to resolve, you see yellowing, just like with a bruise. Microscopically, we start to see macrophage infiltration. Those macrophages are going in to remodel the damaged areas, which is why at this stage, we see a big increase in major structural complications, such as ventricular aneurysms, wall ruptures, or papillary muscle rupture. If the ventricular free wall ruptures, blood spills into the pericardium and it can constrict the heart, leading to cardiac tamponade. Then beyond 2 weeks, up to several months post-MI, grossly we see a gray-white scar on the myocardium, and that scar may be permanent. Microscopically, there's increased collagen deposition and decreased cellularity. So the cellular portions of the myocardium have been replaced with collagen and scar tissue locally. The risks here will include Dressler syndrome, which is post-MI pericarditis. Patients with Dressler syndrome will complain of chest pain. They may have a persistent fever, and on exam, you may be able to hear a pericardial friction rub. So remember Dressler syndrome. And there's still an increased risk of a ventricular aneurysm. There's a scar on the myocardium where the muscle has been replaced with collagen and fibrosis. So what's going to happen to that area when the heart starts to contract? Well, instead of contracting, that scar tissue is going to bulge out with each contraction, and that is a ventricular aneurysm. Let's talk about how we diagnose a myocardial infarction. Now, some of the terminology can get a bit confusing. We group 3 related conditions under the umbrella term acute coronary syndrome. So all 3 are types of myocardial ischemia. There's unstable angina, which we said was chest pain at rest due to transient coronary thrombosis without infarction. So the cardiac enzymes are not elevated in unstable angina. Then there's non-ST segment elevation MI, or NSTEMI, which is thrombosis that does lead to infarction and elevated cardiac enzymes, but on ECG, there's no ST segment elevation. And then there's ST segment elevation MI, or STEMI, which is where you have infarction and elevated enzymes, and the ECG does show ST segment elevation. Now, since we're focusing on MI in this video, let's dig a little bit deeper into the differences between STEMI and NSTEMI. Both of them have elevated cardiac enzymes, but a STEMI is characterized by ST elevation on ECG. An NSTEMI, by definition, does not have ST segment elevation. And you can also diagnose a STEMI if the patient has chest pain plus a new left bundle branch block, since that left bundle branch block can obscure the ST elevation. An NSTEMI will not have ST segment elevation, but you might see some ST depression or T-wave inversions. And both of these have elevated cardiac enzymes. To diagnose an MI, you pretty much have to have biochemical evidence of myocardial injury and necrosis. However, it can take a couple of hours for the cardiac enzymes to start to rise. So in the first 6 hours after an MI, ECG is the most important tool for diagnosing an MI. That is to say, the presence of ST elevation is enough to confirm the diagnosis and then rush the patient off to the cath lab, even without seeing cardiac enzymes first. So what are the classic ECG changes you're looking for? Take a look in the study guide. This is sort of a simplified, stylized ECG just to sort of highlight the changes you need to be able to recognize. So the first one is normal. The ST segment is not elevated, it's even with the PR segment, and the T wave is normal. Then acutely, as the coronary thrombosis occurs and the infarction begins, you see some ST segment elevation. This is sometimes informally called tombstoning because it's bad, right? It's like forming a tombstone. You can also see tombstoning with Prinzmetal's angina due to coronary artery vasospasm. So that's the initial finding. And you'll also notice that the T wave is suddenly enlarged. It can even be sort of tall and peaked or pointed looking, even before the ST segment starts to become elevated. So we call that tall peaked T wave a hyperacute T wave. Then as the MI progresses over the first 24 hours, the ST segment is still elevated and the R wave sort of decreases in amplitude, which is a fancy way of saying the R wave gets smaller. And you can see a Q wave that starts to develop, that's that first negative deflection, starts to develop a Q wave. Basically the MI alters the electrical conduction through that infarcted tissue and the QRS axis is changing. And this is a change over time, which is why we check serial ECGs every 6 to 8 hours initially. Now, during days 1 to 2, we see the T wave becoming inverted, so it flips from a positive deflection to a negative deflection. And we see deepening of the Q wave. Now, days later, the ST segment is normalized, but the T wave remains inverted. And then after a period of weeks, as that infarcted tissue has become a completed scar, the ST and T waves are back to normal, but the Q wave persists. So these are the classic changes associated with an MI, specifically an ST segment elevation MI, or STEMI. But of course, in medicine, not everything's classic. So the main ECG changes you look for to diagnose an MI include ST segment elevation of at least 1 millimeter in 2 contiguous leads, T-wave inversion, a new left bundle branch block, and new Q waves, at least 1 block wide or 1/3 of the height of the total QRS complex. And since the Q waves persist, sometimes permanently, you need to compare the ECG to a previous ECG whenever possible. New Q waves or a new left bundle branch block suggest an acute MI, but Q waves could be present from a prior MI, or the patient could have a pre-existing left bundle branch block, so always compare a prior ECG. Now the bad news is that only about 50% of patients with an acute MI will actually have those classic ECG changes. They're helpful when they're present, but around half the time these changes aren't present. So you can't rule out an MI based on ECG alone. You might have an MI patient with relatively non-specific ECG findings. We said that in the first 6 hours, the ECG is sufficient to diagnose an acute MI. But even if the ECG is normal and there's no ST segment elevation, there could still be some infarction. So that's where the cardiac enzymes come in. As the infarction progresses and myocytes die, they spill their contents into the bloodstream, and we can detect those. So the cardiac enzymes that are most commonly used to diagnose an acute MI include troponin, CKMB, and CK, or creatine kinase. So CK is going to be elevated with any type of muscle damage. It's not specific at all for cardiac muscle. CKMB is somewhat more specific for cardiac muscle, but CKMB can be elevated with other types of muscle breakdown. And then troponin is the most specific for cardiac muscle because it's found in higher concentrations in cardiac myocytes than all these other enzymes. In fact, CK and CKMB are largely obsolete for diagnosing acute MI under most circumstances. Troponin is really where it's at. Troponin starts to rise within 2 to 4 hours after the MI, and it peaks at about 24 hours, and then it stays elevated for about a week. So troponin is most specific for cardiac muscle injury, and it rises very early after an MI, and it stays elevated for a longer time than all these others. So when a patient comes into the emergency department with chest pain, and the ECG shows ST segment elevation, you could diagnose an MI right away and then go ahead and move on to treatment. But if the ECG is inconclusive, you're going to order the cardiac enzymes, especially troponin. And if the first troponin is normal, you're going to recheck it in 6 to 8 hours to see if it's rising. And be aware that other conditions can sometimes elevate cardiac biomarkers, including heart failure, rapid AFib, myocarditis, and sepsis. So be sure to look at the whole picture, including the patient's history, the ECG, and also the cardiac enzymes. Now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go over the answers. All right, first question. Which serum lab markers are commonly used to make a diagnosis of MI? So we mentioned troponin, CKMB, and CK, but troponin is the most sensitive and the most specific. Next, which coronary artery is most commonly occluded in an MI? It's the LAD, the left anterior descending artery. Next, what's the most common lethal complication after myocardial infarction? It's arrhythmia, specifically ventricular fibrillation, or VFib. We're going to talk about the complications of MI in the next video. And then we have one rapid fire fact. Chest pain, pericardial friction rub, and persistent fever occurring several weeks after an MI, that's Dressler syndrome, that post-MI pericarditis. And that's it for now. I'll see you next time.
Welcome back. Let's go through the answers to the Cardiovascular 20 question warm-up. First question, which hereditary hyperbilirubinemia matches each of the following statements? Mildly decreased UDPGT is seen in both Crigler-Najjar type 2 as well as Guillain-Barré syndrome. Completely absent UDPGT is seen in Crigler-Najjar type 1. Grossly black liver is seen in Dubin-Johnson syndrome. Response to phenobarbital is seen in Crigler-Najjar type 2 and also seen in Guillain-Barré syndrome. Treatment includes plasmapheresis and phototherapy is Crigler-Najjar syndrome type 1. And asymptomatic unless under physical stress, for example, because of alcohol or infection, is Guillain-Barré syndrome. Next question. Patients with pulmonary silicosis are at increased risk of what infectious complication? Silicosis increases susceptibility to tuberculosis. as well as other mycobacterial infections. And the last question, what are the pathological characteristics of the arteries in pulmonary hypertension? Histologically, you'll see medial hypertrophy, fibrosis of the intima, and arteriosclerosis. That's it for this 3-question warm-up. Let's move on to the lecture.
Welcome to Myocardial Infarction Part 2, Electric Boogaloo. In this video, we're going to discuss complications of an MI and the treatment of MI. But first, I want to give you a little more detail about what an ECG can tell you about an MI. In the previous video, we talked about the differences between ST segment elevation MI versus non-ST segment elevation MI. So the reason some MIs cause ST segment elevation and others don't has to do with how much of the myocardium was infarcted. On a histological level, we call this transmural infarction versus subendocardial infarction. So to understand what that means, let's review the layers of the heart. The endocardium is the layer that lines the chambers of the heart. It lines the lumen of the heart, if you will. Moving from the interior of the heart toward the exterior surface, there's the myocardium, which is the muscular layer of the heart, and then on the outer surface of the heart, it's covered by the pericardium. So a subendocardial infarct occurs when there's ischemic necrosis of less than 50% of the thickness of the myocardial wall. Remember, the coronary arteries lie near the outer surface of the heart, and they send branches that penetrate or perforate the myocardium to supply oxygen. So if there's a reduction in coronary blood flow, the part of the myocardium supplied by the most distal parts of those arteries are deep inside the myocardium, near the endocardium. So this is a subendocardial infarct. These subendocardial infarcts tend to affect relatively small areas of the left ventricle, and also the interventricular septum or the papillary muscles. And on the ECG, subendocardial infarcts tend to cause ST depression rather than ST elevation. Now let's contrast that with a transmural infarct. By definition, a transmural infarction causes necrosis of the full thickness of the myocardium, usually due to atherosclerosis and thrombosis of a major coronary artery. And this results in much greater degrees of necrosis. So this is more likely to cause ST segment elevation and then later a Q wave. The other important thing that the ECG can tell you is which part of the myocardium has infarcted. And because we know which arteries supply different parts of the myocardium, we can make a pretty good educated guess about which artery has become occluded. In the last video, we mentioned that the most commonly affected artery in an acute MI is the LAD, the left anterior descending artery. And we said that that perfuses the anterior wall. So an occlusion of the LAD will cause ECG abnormalities like ST segment elevation or T-wave inversion in leads V1, V2, and V3, and possibly V4 and V5. So these are considered the anterior wall leads. The circumflex artery perfuses the lateral wall of the left ventricle, which corresponds to leads 1 and AVL, and also leads V5 and V6. The right coronary artery, or RCA, typically perfuses the inferior wall, which corresponds to leads 2, 3, and AVF. And those are called the inferior leads on the ECG. And usually, the right coronary artery gives off the posterior descending artery, the PDA, which perfuses the posterior wall of the right ventricle. So if there's an inferior MI, which is from the RCA, you need to think about the possibility that the posterior heart is also involved. So you're going to do a right-sided ECG, where you put the V1 through V6 leads on the right side of the chest, and you're looking for ST elevation in V4 on the right. But that's pretty advanced information for step 1. Next, let's talk about complications of MI. We mentioned some of these when we talked about the gross and microscopic changes that you see in the heart following an MI, and we said one of the most common complications is arrhythmia. Arrhythmia is common in the first few days post-MI because there's electrical irritability of the heart. So what's the most common lethal cardiac arrhythmia after an MI? It's ventricular fibrillation. Another common complication is left ventricular failure and pulmonary edema because the infarcted myocardium is sort of stunned and the left ventricular pump just isn't contracting very well. And if there's a large left ventricular infarct, that left ventricular failure can result in cardiogenic shock and low blood pressure. Then the next one is ventricular free wall rupture. This occurs when those macrophages are cleaning up the necrotic debris and remodeling the heart, which leads to a weakened area of the ventricular wall that ruptures and it bleeds into the pericardial sac, and this can cause cardiac tamponade. Rupture of the papillary muscle will present as sudden onset of severe mitral regurgitation. So if they give you a patient with an MI and then 5 days later you hear a murmur of severe mitral regurg, think about papillary muscle rupture. Another complication is rupture of the interventricular septum. So instead of the ventricular free wall rupturing, this is a rupture of the septum, which causes a ventricular septal defect, or a VSD. So you may hear a new holosystolic murmur, you may see acute heart failure, especially right-sided heart failure. And we mentioned that an MI might cause formation of a ventricular aneurysm, where the scar tissue in the left ventricle tends to bulge outward as the heart contracts. And that ventricular aneurysm may allow a mural thrombus to form as the blood pools in that bulging aneurysm, and that thrombus could embolize and cause a stroke or a peripheral embolism. So anytime you see a mural thrombus, you need to anticoagulate with warfarin and heparin to reduce thrombus formation and prevent embolization. You can rarely see pericarditis following an MI, specifically a type of inflammatory or non-infectious pericarditis called fibrinous pericarditis. Now we're going to talk about pericarditis in another video, but this presents as pleuritic chest pain 3 to 5 days after an MI, and the pain classically is worse when the patient's lying down, and it gets better when the patient sits up and leans forward. And you may hear a pericardial friction rub on your physical exam. And then Dressler syndrome is an autoimmune pericarditis that occurs several weeks after an MI. We're going to wrap up this video by reviewing the treatment of MI. So this is going to sort of be a high-level view, focusing on the big picture and general principles without getting lost in the details. For example, the treatment options may vary depending on whether you're in a major hospital with a cath lab in the next room versus out in a community hospital somewhere in the middle of nowhere, and the nearest cath lab is a couple hours away. And then the treatment of ST segment elevation MI, or STEMI, is different from the treatment of a non-ST segment elevation MI, or NSTEMI. But initially, a lot of the treatment is going to be the same. So you start with the ABCs, airway, breathing, and circulation. We give supplemental oxygen as needed, only if the patient's pulse ox is less than 90%. So not everybody needs supplemental oxygen. Early on, usually in the ambulance, we're going to give aspirin to inhibit the platelets and prevent further thrombosis of the affected coronary artery. We also give a nitrate, like sublingual nitroglycerin, to dilate the peripheral veins and decrease preload, which reduces the work of the heart and the myocardial oxygen demand. But that decreased preload means that the blood pressure is going to drop, so watch out for hypotension. Now, we used to give morphine routinely to MI patients, but that's no longer routinely recommended unless the patient has severe uncontrolled chest pain. So if you remember the old mnemonic MONA, or moan, or bemoan, we don't really use that mnemonic anymore because we don't routinely give morphine. And again, not everybody gets oxygen anymore either. Now, you give a cardioselective beta blocker like oral metoprolol or maybe atenolol, as long as there are no contraindications like heart failure or hypotension or acute bronchospasm like asthma. You're going to give a statin, usually atorvastatin, and preferably you're going to give this before going to the cath lab and doing any stenting. All patients should receive antiplatelet therapy such as clopidogrel in addition to the aspirin. You're trying to combat that thrombosis. We also give anticoagulant therapy to all patients. And this starts to get a little complicated, but as a general rule of thumb, you give unfractionated heparin to all patients undergoing PCI, or percutaneous coronary intervention, stenting. And we give enoxaparin, which is a low molecular weight heparin, for patients not managed with PCI. And note, these are all parenteral anticoagulants. We're not using warfarin or other oral anticoagulants in these patients. And finally, we give potassium and magnesium to keep the serum potassium above 4 and keep the mag above 2 to decrease the risk of arrhythmias. What if the patient becomes hypotensive while you're treating him? What do? Well, you need to stop the nitrate and give IV fluids. Nitrates like nitroglycerin are vasodilators, so if you're using a nitroglycerin paste on the skin or maybe a nitroglycerin drip, you can stop that. But if you've given sublingual nitroglycerin, you can't really get rid of that nitroglycerin effect. So all you have to do is fill up the vascular space by giving fluids. So fill up all those vessels with fluid so you get the preload back. So that's the basic initial treatment for all MIs. Now beyond that, we start to differentiate based on whether the patient has STEMI or an NSTEMI. So if it's a STEMI, then you have to pick a reperfusion strategy. So percutaneous coronary intervention, or PCI, is strongly preferred as reperfusion strategy. The goal is to have that vessel open within 90 minutes of the first medical contact. So we say door to balloon time of 90 minutes or less. Now if PCI is unavailable, or if PCI is going to be delayed more than 120 minutes, then fibrinolytic therapy is recommended. And unlike in strokes, with an MI, you can give thrombolytics up to 12 hours after the onset of symptoms. But sooner is always better. The key issue is that you want to do something to open up that thrombosed vessel and reperfuse the myocardium. In patients with NSTEMI, fibrinolytic therapy is not indicated. Fibrinolysis is only for STEMIs. NSTEMIs will go to the cath lab, but no thrombolytics. With an NSTEMI, you may send them to the cath lab urgently, like if they're an unstable patient, meaning things like shock or severe heart failure or sustained VTAC. But stable patients with an NSTEMI can go to the cath lab later in 12 to 24 hours. And then finally, if the cath shows severe coronary artery disease, 3-vessel disease, or maybe a tight stenosis in the left main artery, the patient may be a candidate for a coronary artery bypass graft rather than PCI. So that's all for acute, urgent management of an MI in the hospital. But what about long-term management? These patients need to be on long-term aspirin and or clopidogrel, depending on their scenario. They need to be on a beta blocker, and either an ACE inhibitor or an ARB. They should be on an aldosterone antagonist, such as spironolactone or eplerenone. They also need to be on a statin, really regardless of their LDL. Many of these medications have been shown to decrease mortality in MIs, and they include things like beta blockers, ACE inhibitors, and statins. All are going to decrease mortality. And then don't forget to coach these patients on lifestyle modification to reduce their risk factors. So this can include things like exercise, smoking cessation, and dietary modification. And now we're ready for the end of session quiz. So pause the video and answer those questions, then restart the video and we'll go over the answers together. First question, what would cause each of the following findings following an MI? So cardiac tamponade, should think about rupture of the ventricular wall with bleeding into the pericardium. Severe mitral regurgitation would be caused by rupture of the papillary muscle or possibly papillary muscle dysfunction. A new VSD would be seen in rupture of the interventricular septum. And a stroke following an MI should make you think about a mural thrombus that formed in the heart, and then part of the thrombus has broken off and become an embolus. Next, which ECG leads will show evidence of ischemia in an anterior wall MI? Think about leads V1 through V4. Next, how would you manage a patient presenting with an acute myocardial infarction? So again, you're starting with the ABCs. You're going to give supplemental oxygen only as needed for pulse ox less than 90%. You give aspirin and nitrates like nitroglycerin. You give a beta blocker, usually oral metoprolol as long as there's no heart failure. You give a statin, usually atorvastatin, and preferably before going to the cath lab. You give antiplatelet therapy, usually clopidogrel, and anticoagulant therapy, either heparin or enoxaparin. And remember, which one you're going to give depends on whether or not they're going to the cath lab. You're going to give potassium and magnesium as needed to normalize those levels. That may help prevent fatal arrhythmias like VTAC. And then if the MI is a STEMI, you do a cath and PCI if possible, or fibrinolysis if the cath lab is not available. And if it's an NSTEMI, you may do PCI, but again, no fibrinolysis. And that's it for now. I'll see you next time.
Welcome to Big Booty Burger. Would you like to try our new badonkadonk burger with J-Lo fries?
Yeah, just give me one extra large Big Booty double with cheese, and make it a combo meal with a Coke. No, a Diet Coke.
Have you had your cholesterol checked lately? By the sound of your order, you might want to think about it.
What? Mind your own business, son. Just give me my burger. Oh, and add a chocolate milkshake while you're at it.
Sorry, can't do it. You, my friend, are well on your way to a heart attack. Can you tell me what drugs can be used to reduce myocardial oxygen demand in a patient having a heart attack?
Myocardio what? I said a large booty double.
Sorry, that's the wrong answer. The correct answer is a nitrate to reduce preload, an ACE inhibitor or ARB to reduce afterload, and a beta blocker to decrease contractility and heart rate.
What? Just give me my food, or get your supervisor on the line.
Fine. Your total will be $7.99. Please drive through and have a big and bootyful day.
That's what I thought.
Seriously, people, it's called a salad. You should try it sometime.
It's time for the 3-question one for Cardiovascular 21. Let's get going. At what age should patients begin receiving screening colonoscopies? So the big ones to know are 50 years of age, and that's for everyone. If there's a family history, then potentially at 40 years of age or 10 years before the youngest first-degree relative diagnosis, whatever comes first. Other clinical scenarios would require more aggressive screening. A familial adenomatous polyposis, or FAP, every 12 months starting at around age 10 to 12 and continuing until age 35 to 40. If negative, Lynch syndrome is apparent, you got to begin at about 20 to 25 years of age or 10 years before the youngest relative diagnosis. Next question, what is the triad of a Cardiovascular syndrome? What is the underlying defect? So the triad of a Cardiovascular syndrome is situs inversus, bronchiectasis, and recurrent sinusitis. And the underlying defect is a dynein arm defect, so you have immotile cilia causing those clinical effects. Next question, what are the classic symptoms of carcinoid syndrome? So remember the mnemonic BFDR, so bronchospasm and wheezing, right-sided heart lesions, diarrhea, and flushing. All right, that's it for the warm-up. Let's get to that lecture now.
We have a lot of ground to cover in this video, including cardiomyopathies, myocarditis, and endocarditis. So let's get right to it. We'll start with cardiomyopathies. First of all, what exactly is a cardiomyopathy? Well, it's a myopathy, a muscle pathology of the myocardium. So we're talking about problems with the heart muscle itself. There are three distinct cardiomyopathies we're going to talk about: dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. So dilated cardiomyopathy is by far the most common of the three, but I want to start with hypertrophic cardiomyopathy because that's the one that you're most likely to be tested on. Very high yield, and it's pretty interesting. You may have heard it called hypertrophic obstructive cardiomyopathy, or HOCM, or HOCM, or you might hear it called IHSS, which stands for idiopathic hypertrophic subaortic stenosis. But the preferred name is just plain hypertrophic cardiomyopathy. Now, this is primarily a hereditary disease. At least 50% of cases are autosomal dominant. In hypertrophic cardiomyopathy, you have disordered hypertrophy of the left ventricle, tangled, chaotic, disordered myocytes, not the orderly, parallel myocytes that you see with LVH due to chronic hypertension. The interesting thing about hypertrophic cardiomyopathy is what it does to the hemodynamics. You get a lot of hypertrophy of the interventricular septum, and because it's so enlarged, it's actually too close to the opposite wall and the mitral valve leaflets, and this causes outflow tract obstruction. So the blood actually can't get out of the ventricle. On physical exam, the apical impulse is enlarged and diffuse. So instead of the apical impulse being about the size of a nickel, it's quarter size or even silver dollar sized. The heart is normal in size, but that apical impulse is just sort of diffuse and ill-defined. You might hear an S4 heart sound because that thickened ventricle is stiff and non-compliant. Remember, an S4 is associated with a stiffened ventricle to the point where the atrium is having a hard time filling that stiffened ventricle. And then you'll also hear a systolic murmur because hemodynamically this is very similar to aortic stenosis. But remember, this is subaortic stenosis. So you have outflow tract obstruction just like you would with aortic stenosis, but the problem is actually proximal to the valve. So you're going to hear the systolic murmur, and maybe you remember when we talked about heart murmurs, we said that the Valsalva maneuver is going to make most murmurs quiet, except for this murmur of hypertrophic cardiomyopathy. Valsalva actually makes this murmur louder. So when you Valsalva, you're increasing the intrathoracic pressure and you're reducing filling of the heart so that you're reducing preload, and that actually means that the hypertrophied septum is closer to the lateral wall of the ventricle. So the left ventricular outflow tract obstruction is worse. So this murmur gets louder with Valsalva. There's more obstruction. That's one clue you can use to distinguish hypertrophic cardiomyopathy from aortic stenosis on physical exam. Valsalva makes this murmur louder. And then what does squatting do? Remember, we said squatting increases afterload, and that tends to make this murmur softer. If you have increased afterload, that's going to favor a little more blood in the left ventricle, and that extra blood is going to push the septum away from that lateral ventricular wall, so there's less obstruction. So one more time, Valsalva makes the murmur of hypertrophic cardiomyopathy louder, and squatting makes this murmur softer. Then the highly testable point to make is that hypertrophic cardiomyopathy is the most common cause of sudden death among young, healthy athletes in the U.S. So when you hear about a high school football player who drops dead during two-a-days, think about hypertrophic cardiomyopathy. What happens is, remember, these patients need preload to keep that outflow tract somewhat open. So when these patients exercise strenuously and they get volume depleted, the preload drops precipitously, the patient dies. And then we treat hypertrophic cardiomyopathy with either a beta blocker or a non-dihydropyridine calcium channel blocker like verapamil. because those kind of drugs are going to slow the heart and prolong diastole, and that's going to increase ventricular filling. These drugs also reduce the oxygen demand on the heart. You also want to restrict physical exertion and avoid volume depletion. So, like I said, hypertrophic cardiomyopathy is very high yield. The next type of cardiomyopathy is restrictive cardiomyopathy or obliterative cardiomyopathy. So basically what happens here is deposition of a bunch of stuff in the myocardium, and that disrupts diastolic function. So the muscle just becomes very thickened and it's restricted from functioning normally. So it's called restrictive cardiomyopathy. So what diseases and what kind of stuff can infiltrate the myocardium like this? Well, sarcoidosis with granulomas infiltrating the myocardium, amyloidosis with lots of abnormal amyloid protein, Loeffler syndrome causes fibrosis of the endocardium and infiltration with eosinophils. Now, you might be thinking to yourself, Loeffler's, I've heard that somewhere before. What was Loeffler syndrome? Well, there's also Loeffler's eosinophilic pneumonitis due to Ascaris lumbricoides. Now, that's slightly different, but this is also related to hypereosinophilia. But here you're getting eosinophilic infiltrates in the heart, and that leads to fibrosis and restrictive cardiomyopathy. Or sometimes you can get an eosinophilic myocarditis. So don't mix those two things up. The big thing is if you hear Loeffler's, think about eosinophils. And then hemochromatosis can cause iron deposition in the myocardium. Now, pay attention to this. Hemochromatosis more commonly causes a dilated cardiomyopathy, which we're going to get to shortly. But alternately, it could cause a restrictive cardiomyopathy. You can also have fibrosis of the heart following radiation therapy. Maybe a patient received radiation to the chest for lung cancer or breast cancer, and unfortunately that puts the heart smack dab in the middle of that radiation field. So you can have infiltration of the myocardium with fibrous tissue. And then there's a congenital problem called endocardial fibroelastosis, where you have thick fibroelastic tissue in the endocardium of young children. And then a student sent in a mnemonic for all these different causes of restrictive cardiomyopathy. It is you use a leash to restrict your dog. Leash, L-E-A-S-H. So L is for Loeffler syndrome, E is for that endocardial fibroelastosis, A is for amyloidosis, S is for sarcoidosis, and the H is hemochromatosis. Then the third and final type of cardiomyopathy is dilated cardiomyopathy. We said that dilated cardiomyopathy is by far the most common of the three. About 90% of cases of cardiomyopathy are dilated, which makes sense because there are a ton of things that can cause dilated cardiomyopathy, especially chronic myocardial ischemia, which we know is very prevalent in our society. We're going to get to all the different causes of this shortly. But what exactly is dilated cardiomyopathy? Well, it's where the heart dilates. The heart muscle is not thicker and hypertrophied, but it's bigger around, like you're blowing up a balloon. So instead of adding myocytes and sarcomeres in parallel, you're actually adding these sarcomeres in series so that the ventricle just gets bigger and bigger and the heart is distorted and dilated looking. And the problem is that this rounded globular shape isn't really conducive to good muscle mechanics, so the ventricle can't contract like it's supposed to, and you get systolic dysfunction. Now, on physical exam, you're going to have an S3 heart sound. Remember, S4 is due to a stiffened left ventricle, like in hypertrophic cardiomyopathy or restrictive cardiomyopathy. But an S3 is from ventricular systolic failure. You're also going to find that the apical impulse is displaced laterally. Now, instead of being in the midclavicular line, it's farther out toward the mid-axillary line. And again, that's just because the heart is enlarged and the apex is just pushed farther out. Now, I mentioned earlier that there are a ton of things that can cause dilated cardiomyopathy. Chronic myocardial ischemia is a big one, a very, very common one. Patients who get CHF from long-standing ischemic heart disease most likely have dilated cardiomyopathy. We mentioned hemochromatosis. Now, most of the time, if hemochromatosis affects the heart, it's going to cause this dilated cardiomyopathy. But again, occasionally you can have that other restrictive cardiomyopathy. There's a class of chemotherapy drugs called anthracyclines that are known for causing cardiotoxicity, and specifically they cause this dilated cardiomyopathy. So the drugs are doxorubicin and daunorubicin. Doxorubicin and daunorubicin cause dilated cardiomyopathy. Chronic cocaine use can cause it, so can chronic alcohol use. Another cause is wet beriberi. Now, beriberi is caused by thiamine deficiency. Thiamine is vitamin B1, and if you turn the I's in beriberi into the number ones, it's going to remind you of B1 deficiency and thiamine deficiency. Now, we just mentioned alcohol use, and alcoholics can develop thiamine deficiency, right? That's what causes Wernicke-Korsakoff syndrome. Well, thiamine deficiency can also lead to wet beriberi, which is characterized by dilated cardiomyopathy and heart failure. In fact, it's called wet beriberi because of the peripheral edema due to CHF. You have all this extra fluid, so it's wet beriberi. So chronic alcohol use can either cause dilated cardiomyopathy on its own, because the alcohol is directly toxic to the myocardium, or chronic alcohol use can cause thiamine deficiency, and that leads to wet beriberi. Another cause of dilated cardiomyopathy is Chagas disease, which is an infection by the protozoa Trypanosoma cruzi. So remember, Chagas disease leads to dilated cardiomyopathy and megacolon, and it causes megaesophagus. So everything's getting enlarged with Chagas disease. Then one more cause of dilated cardiomyopathy to mention is myocarditis from Coxsackie B virus. Let's talk about myocarditis for just a second. Look at number 4 in your study guide. First of all, myocarditis is an itis. It's inflammation. It's generalized inflammation of the myocardium that does not result from ischemia. The most common cause in the U.S. is Coxsackie B virus. Now, lots of other viruses can cause myocarditis, but the main one is Coxsackie virus. Histologically, you have a diffuse interstitial infiltrative lymphocytes, and then you see myocyte necrosis. So diffuse interstitial infiltrative lymphocytes with myocyte necrosis. So it's inflammation to the point of necrosis. Now let's talk about endocarditis, specifically bacterial endocarditis, or the more accepted name is infective endocarditis. So first, some semantics. Endocarditis just means inflammation of the inner layer of the heart, the endocardium. Now, it usually involves the valves, but it can also involve other structures like the septum or the chordae tendineae. But for the most part, when you hear endocarditis, think heart valves. And then the reason we're making the distinction about infective endocarditis is that sometimes you can get sterile endocarditis from non-bacterial causes like metastatic cancer or a hypercoagulable state or from lupus. We'll come back to that. Just remember that itis doesn't necessarily mean infection. Itis just means inflammation. Now, endocarditis is characterized by lesions or vegetations. A vegetation is a mass of platelets and fibrin and colonies of microorganisms and inflammatory cells, and all this gunk just sort of sits on the valve leaflets. And these vegetations can either fibrose or calcify, which can lead to further problems as well. Let's talk about the signs and symptoms of infective endocarditis. I'm going to go through this in your study guide number 5. The most common symptom is fever, and it may be the only symptom initially. You can also get vague, nonspecific symptoms like weakness and fatigue or anorexia, not very helpful symptoms by themselves. Next one is a new regurgitation murmur. So patients who didn't previously have a murmur now all of a sudden have one, and that's a big tip-off you've got some endocarditis. The mitral valve is the most common site of endocarditis. We said that this can cause mitral regurgitation. That inflammation is just gradually chewing up the valve so it won't close all the way and you get some regurgitation. So you'll hear about left-sided endocarditis, which is typically the mitral valve, or you might hear about right-sided endocarditis, which is typically the tricuspid valve. And remember, tricuspid endocarditis is classically associated with IV drug abuse. Then many of the signs and symptoms we see from endocarditis are actually due to septic emboli. These small bacterial emboli can break off from those vegetations and travel to other areas of the body and embolize there. Now, if you have tricuspid endocarditis, where would those emboli go? Well, they go to the pulmonary circulation, so you could have septic pulmonary emboli and pulmonary infarcts. You might see splinter hemorrhages in the nail beds, which are septic emboli from the left side of the heart, the systemic side, going all the way out to the fingertips or to the toes. You can also see something called Osler nodes. These are tender, painful nodules on the fingertips or the finger pads. These are named after Sir William Osler, that famous internist from Johns Hopkins, one of the fathers of modern medicine. Now, Dr. Lewis likes to think about Dr. Osler really palpating patients very aggressively, and it makes his fingers painful. Personally, I just think about how painful it would be to go on teaching rounds with Dr. Osler. Anyway, Osler nodes are painful, and that's important to distinguish them from Janeway lesions, which are painless erythematous lesions on the palms and the soles of the feet. So remember, Dr. Osler is painful, and then Janeway lesions sound a little more feminine, maybe gentler, less severe. They're painless. And then Osler nodes are more on the fingertips anyway. You might also see Roth spots on the retinas, which are retinal hemorrhages with a round white area in the center. And these are pretty rare, so remember, Roth spots, retina, rare. Then you can also have emboli to the brain, which cause focal neurodeficits. So basically this is going to present like a stroke. You can have emboli to the kidneys, which causes renal infarct and hematuria. Or you could embolize the spleen and cause pain in the abdomen or referred pain in the shoulder. Then you might see glomerulonephritis or arthritis from a systemic immune reaction. So how do we diagnose endocarditis? Well, other than looking for all these exam signs, you need multiple blood cultures. So you should always try to get your blood cultures before you start antibiotics. And you need to do an echocardiogram to look for those vegetations on the valves. That's one of the important criteria for diagnosing endocarditis. And usually you need a transesophageal echo, or a TEE, where you place the ultrasound probe down in the esophagus so that it's right up against the valves as much as possible. This isn't the standard transthoracic echo where you put the probe on the chest. There are several other diagnostic criteria that probably aren't very high yield for your test, so we're not going to go over them. Let's talk more about the specific organisms that cause infective endocarditis in a little more detail, because that is very high yield. 75% of cases of endocarditis are from one of 4 bacteria: Staph aureus, viridans strep, like strep mutans, Enterococci, like Enterococcus faecalis, and Staph epidermidis. And while we're here, I want to remind you that there's no such species as Streptococcus viridans. Viridans is an unofficial grouping of a bunch of different species of strep. So don't say strep viridans, say viridans strep if you have to talk about these at all. So again, it's Staph aureus, viridans strep, Enterococci, and Staph epi. So let's spend just a few minutes talking about each one of these one by one. Staph aureus accounts for roughly 30% of cases of endocarditis. And this is acute endocarditis. These patients can be very sick, and they get sick very, very quickly, very acutely. And with acute infective endocarditis, you're going to get these large vegetations on previously normal valves. The next most common cause are the viridans strep. Viridans strep accounts for about 20 to 30% of all endocarditis, only slightly less common than Staph aureus. And viridans strep cause subacute endocarditis with a gradual, insidious, subacute onset. So with subacute endocarditis, you also get smaller vegetations, primarily on valves that were already abnormal, like a bicuspid aortic valve, or on a prosthetic heart valve, or a valve that had already been damaged by rheumatic heart disease. Also think about dental procedures. Subacute endocarditis from viridans strep can be a sequela of a dental procedure in a patient who has abnormal valves. That's why we give prophylactic antibiotics to patients with abnormal valves before they go in for a dental procedure where the gums are going to be manipulated or where the oral mucosa is going to be disrupted. Basically, you don't want bacteria from the mouth to get into the bloodstream and seed those abnormal valves. But you don't have to give prophylaxis to patients with normal valves. And if you have a patient with a known abnormal valve, but he's just going in for a routine cleaning and there's not going to be any gingival manipulation, you don't need to give antibiotics for that either. The third most common bacterial cause of endocarditis is Enterococcus. Enterococci make up about 10% of cases. Now, the big reason to worry about Enterococci is that some strains are developing resistance to vancomycin. We call this vancomycin-resistant Enterococci, or VRE. If you get that in your heart, it's very hard to treat. And then coagulase-negative staph, like Staph epi, are responsible for about 5 to 10% of cases. So Staph epi is a normal flora on the skin, but it's not so good for the heart. Imagine that scenario of the IV drug user who's picking up bacteria from the skin. Staph aureus and strep are still more common in IV drug users overall, but think about Staph epi also. IV drug users can also have unusual bacteria like Pseudomonas or even fungal endocarditis like Candida. Another less common bacteria is Strep bovis. Now, Strep bovis is associated with colon cancer. So if you ever get a blood culture that grows Strep bovis, with or without endocarditis, you need to get a colonoscopy and make sure there's not a colon cancer hiding out. And then finally, what if you have endocarditis but the blood cultures are negative? Well, the patient has all those signs and symptoms and the echo shows vegetation but nothing's growing on the cultures. We call that culture-negative endocarditis. Now, in the old days, up to about 10 years ago, the classic traditional culprits for culture-negative endocarditis were called Hassic organisms. And Hassic stands for Haemophilus, Actinobacillus, the C is for Cardiobacterium, the E is Eikenella, and the K is Kingella. Now, those are all pretty rare causes of endocarditis. And with modern lab techniques, they're much easier to culture than they used to be. So nowadays, the 3 most common causes of true culture-negative endocarditis are probably Coxiella burnetii, which is the bacteria that causes Q fever, Bartonella species, including Bartonella henselae, which is what causes cat scratch fever, and then Brucella species, which is a zoonotic disease that you get from animals, especially from drinking unpasteurized milk. And what characteristics do all 3 of those bacteria share? They're all intracellular bacteria, which probably explains why they're not easy to culture from the blood. And then finally, what are the complications of infective endocarditis? Well, we talked about all the embolic complications like strokes and renal infarction. You can get glomerulonephritis. You can get structural damage to the infected valve. The bacteria and all that inflammation just sort of chew up the valves, and that leads to valvular regurgitation or valvular stenosis. And some patients will end up needing valve replacement after having infective endocarditis. If the vegetation extends to the chordae tendineae, they can rupture, and that can lead to acute onset of mitral or tricuspid regurgitation. And then one unusual complication is suppurative pericarditis, which is weird because the pericardium is outside the heart and the endocardium is inside the heart. But once you've got bacteria and inflammation in there, it can start to spread around. I also want to briefly mention a couple of non-infective causes of endocarditis. The first one is Liebman-Sachs endocarditis, which is caused by systemic lupus erythematosus, or SLE. And back when we talked about lupus, I said that SLE causes LSE, or Liebman-Sachs endocarditis. So these are sterile vegetations, and these occur on both sides of the valve. The vegetations in infective endocarditis tend to form on just one side of the valve, but these Liebman-Sachs vegetations form on both sides of the valve simultaneously. So if this is the mitral valve, you're going to see vegetations on the atrial side and on the ventricular side. And then there's another non-infective endocarditis called merantic endocarditis, which is sterile vegetations either caused by metastatic cancer cells or by platelet fibrin aggregates in patients with hypercoagulable states. So just be aware that that exists. All right, now it's time for your end of session quiz. Let's go through these. First question, what are the differences between acute and subacute infective endocarditis? So acute infective endocarditis is most commonly caused by Staph aureus. The onset is very rapid, and it can affect normal valves. With subacute endocarditis, the most common cause is Viridans strep, and it's going to be affecting previously damaged or congenitally abnormal valves. And it has a subacute insidious onset over the course of weeks or months, whereas acute endocarditis could happen over days. Next, an IV drug user presents with chest pain, dyspnea, tachycardia, and tachypnea. What's the most likely cause? Well, this patient has infective endocarditis. And of course, you might expect fever and a new murmur associated with this also. But specifically what's happening here is you have a bacterial embolism causing other things as well. So this could be a right-sided infective endocarditis with embolization into the pulmonary arteries causing septic pulmonary emboli. Next question. A young girl with congenital valve disease is given penicillin prophylactically. In the ER, infective endocarditis is diagnosed. What's the next step in her management? So IV vancomycin is the preferred empiric drug for infective endocarditis until the culture comes back, because vancomycin is going to cover both staph and strep, including MRSA. So don't try to treat endocarditis empirically with a penicillin. Then when the culture comes back, you're going to switch to an antibiotic that's most appropriate for that particular bacteria's susceptibilities. All right, that's it for the quiz, but let's go ahead and go over these rapid-fire facts. Splinter hemorrhages under the fingernails are associated with infective endocarditis. Retinal hemorrhages with pale centers are called Roth spots, and we said those are also associated with infective endocarditis. The heart valve most commonly involved in infective endocarditis is going to be the mitral valve, and the heart valve most commonly involved in an IV drug user with infective endocarditis is the tricuspid valve. All right, that's it for Cardiovascular 21. I'll see you next time.
It's time for the 3-question warm-up for Cardiovascular 22. Let's get going. Identify the hepatitis B status of each of the following patients based on their hepatitis B serologic markers. So the first one, negative surface antigen and positive surface antibody and core antibody. This is the recovery phase. Second one, core antibody positive, but the others are negative. This is going to be the window phase. Next one, positive surface antigen and positive core IgM. That's going to be acute disease. Next one with a positive core IgG, that's going to be chronic disease. And the last one with positive surface antibody only, that's going to be a patient who has been immunized. Next question, which tumors arise centrally in the lung and are linked to smoking? And then which tumors tend to arise peripherally in the lung? So which tumors first are central in the lung and are linked to smoking? Those are your S's, S for smoking. So that's going to be squamous cell, small cell, smoking, central, all the S sounds. Now, which tumors tend to arise peripherally in the lung? That's going to be adenocarcinoma and large cell carcinoma. Next question. A 20-year-old man contracts influenza, then presents with an idiopathic hyperbilirubinemia. What is the most likely cause? So this is a classic scenario for Gilbert syndrome, so you need to know that one. All right, so that's going to be it for the warm-up. Let's get to that lecture now.
Ground control to Major Tom. Commencing countdown, engines on. Oh, you caught me. I like to come up here sometimes between videos. You know, kind of relax and clear my head. Hey, McGinnis, wait up!
Oh, I don't feel so good.
I let Dr. Lewis tag along sometimes, but he gets kind of space sick. And on that note, I guess it's time to get started with the lecture. See you back on Earth. Welcome back. How'd you get down here so fast? How'd I get down here so fast? In this video, we're going to talk about a grab bag of cardiac pathologies, including rheumatic heart disease, pericardial disease, and finally a couple of cardiac tumors. So let's start with rheumatic heart disease. Rheumatic heart disease is a consequence of a bacterial infection, but it's actually an autoimmune phenomenon. This is where you have strep throat, group A beta hemolytic strep pharyngitis, strep pyogenes. And one possible outcome of an untreated group A strep infection is acute rheumatic fever. So your body fights off the acute infection, but then a couple of weeks later, you get autoantibodies that attack the heart and other organs. So it's a type 2 hypersensitivity. There are actually 4 possible non-suppurative complications of group A strep infection. There's scarlet fever, which is where you get a widespread sandpaper rash all over the body, usually while you still have the strep throat. This is toxin-mediated. There's post-streptococcal glomerulonephritis, which is an immune complex-mediated type 3 hypersensitivity that causes hematuria and proteinuria and renal insufficiency, usually 1 to 6 weeks following a group A strep infection. There's acute rheumatic fever, which is a type 2 hypersensitivity where the autoantibodies are directly attacking the tissues, usually 2 to 4 weeks after a bout of strep pharyngitis, mostly in kids. And then there's strep toxic shock syndrome, which is more likely to follow a group A strep skin infection or sometimes a vaginal infection, but sometimes strep pharyngitis can lead to it. Now we're going to lay all of those aside for right now, except for acute rheumatic fever, because that's the one that affects the heart. So let's go over the diagnostic criteria for acute rheumatic fever in the study guide. These diagnostic criteria are called the Jones criteria. First of all, you have to have evidence of a group A strep infection, like an elevated anti-streptolysin O titer, plus either 2 major criteria or 1 major and 2 minor criteria. And if you have either of those, that's going to give you a high probability of rheumatic fever. The major criteria spell out the word Jones. So the J is for joints, which is a migratory polyarthritis. Then you draw the O in the shape of a heart, which tells you this is pancarditis. Rheumatic fever will cause endocarditis, myocarditis, and pericarditis all at the same time, so we call that pancarditis. N is for nodules, which are painless subcutaneous nodules. The E is for erythema marginatum, which is a serpiginous rash on the skin. Now, serpiginous means creeping or spreading. It starts small and it creeps outward like large irregular rings. So these are ring-like rashes that can appear and disappear over a few hours. So they come and go. It's also called erythema annulare, like an annular lesion, a ring-like lesion. And then Sydenham chorea is a chorea of the face and tongue and upper limbs. Sometimes it's referred to as St. Vitus's dance. So either S term will work. St. Vitus dance or Sydenham chorea. So these are choreiform movement, rapid, writhing, uncontrollable movements, primarily in the face and the tongue and the upper limbs. Then the minor criteria are less important to know. They spell out the word peace. So the P is for the prolonged PR interval, the E is for elevated temperature or fever, the A is for arthralgias, and then technically the C and E go together. So C is for elevated CRP and E is for elevated ESR. And if either of those is elevated, it counts as only 1 minor criterion. So again, evidence of group A strep infection plus either 2 major criteria, which is the Jones mnemonic, or 1 major and 2 minor criteria, which is the Peace mnemonic. But you should definitely know the major criteria. Now, in terms of the heart disease, patients with rheumatic fever might have myocarditis that can be potentially fatal, but more commonly, the patient's going to survive and they're going to have autoimmune damage to the valves, most commonly the mitral valve, but it could be the aortic valve. We talked about that when we talked about heart murmurs. You can have mitral regurgitation as an early lesion, and then it can progress to mitral stenosis. Now, on labs, you can also see elevated anti-streptolysin O titers. So the heart disease with elevated ASO titers is probably going to be rheumatic heart disease. And then histologically, you'll see Aschoff bodies, which are pathognomonic for rheumatic heart disease. Aschoff bodies are little inflammatory nodules within the myocardium, where you have areas of fibrinoid necrosis infiltrated by lymphocytes and multinucleated giant cells. So it's a type of granuloma. You can also have Anichkov cells, which are activated histiocytes with an owl eye appearance. Next, let's talk about acute pericarditis, which is inflammation of the pericardium, that sac around the heart. So there are lots of things that can cause pericarditis, and there are different types of pericarditis. There's fibrinous pericarditis, which can be due to uremia or renal failure, or it can be due to rheumatoid arthritis, or due to Dressler syndrome, which is that pericarditis that occurs several weeks post-MI. There's serous pericarditis, which is caused by non-infectious inflammatory diseases like lupus or rheumatic fever. Remember, we said rheumatic fever causes pancarditis, which involves the pericardium. But on your test, they might give you a patient with the classic presentation, pleuritic chest pain and a friction rub. Then they would have to give you something else to lead you to a specific diagnosis, like a positive ANA, which would suggest lupus pericarditis. Then there's also suppurative pericarditis, which is where you have an infection of the pericardium and pus in the pericardial space. That's what suppurative means, pus forming. Sometimes you can have hemorrhagic pericarditis due to tuberculosis or malignancy, specifically melanoma. For whatever reason, melanoma likes to metastasize to the heart. It goes to lots of different places, but it's one of the more common cancers that causes cardiac mets. Now, what does acute pericarditis look like clinically? Well, it often causes pleuritic chest pain, which is sharp pain that gets worse with inspiration, and it gets better when you're sitting up and leaning forward. On exam, these patients can have distant heart sounds. You may also hear a friction rub, which sounds like a rhythmic sandpaper or leathery sounds on auscultation. It's kind of hard to describe, but the first time you hear one, you'll probably be like, what on earth is that? And then somebody will tell you it's a friction rub, and you'll be like, oh, I got it. And then on EKG, you're going to look for diffuse ST segment elevation. So if you see ST elevation in a specific pattern, like ST elevation in lead 1 and VL, that's a lateral MI, right? Or ST elevation in leads 2, 3, and AVF, that's an inferior MI. But if you see diffuse ST elevation in all 12 leads, that's not an MI, that's pericarditis. You can also see diffuse PR segment depression, so be aware of that. And then finally, pericarditis can either resolve without scarring, or it can lead to chronic constrictive pericarditis. One of the most common causes of constrictive pericarditis is lupus. Now, chronic constrictive pericarditis will cause all those same findings as the other types of pericarditis, but you're also going to have Kussmaul's sign. Kussmaul's sign is when you have jugular venous distension during inspiration. We'll go back to that for a moment, but for right now, just remember JVD during inspiration. Now, what normally happens when you take a breath? Intrathoracic pressure drops, and the right ventricle fills. So normally, the jugular veins would be flat during inspiration. So jugular venous distension during inspiration is abnormal, and that's Kussmaul's sign, and that's due to chronic constrictive pericarditis. Let's talk about cardiac tamponade. Cardiac tamponade is where there's excessive fluid in the space between the myocardium and the pericardium, either blood or a huge pericardial infusion. And that fluid is compressing the heart, preventing the heart from being able to expand and fill during diastole. Tamponade leads to decreased cardiac output and equilibration of diastolic pressures in all 4 chambers. Because of this, the patient's going to have hypotension, increased venous pressure in JVD, distant heart sounds, increased heart rate, and pulsus paradoxus. So, what's pulsus paradoxus? Pulsus paradoxus is an exaggerated decrease in the amplitude of the systolic blood pressure during inspiration. What on earth does that mean? Well, this is kind of a tricky concept for a lot of students, so let's break it down. During inspiration, your intrathoracic pressure decreases. Blood fills the right side of your heart, first the right atrium and then the right ventricle, and this kind of pushes the interventricular septum over toward the left a little bit. So the left ventricle is going to be somewhat smaller during inspiration than during expiration, since that septum is being pushed over during inspiration. So if the left ventricular volume is smaller and you're pushing less volume out of the left ventricle, systolic blood pressure is going to be very slightly lower during inspiration. And that's a perfectly normal phenomenon to have lower systolic pressure during inspiration. But this phenomenon is exaggerated with pulsus paradoxus. So again, pulsus paradoxus is an exaggerated decrease of the systolic blood pressure by more than 10 millimeters mercury during inspiration. So it's a drop in the blood pressure by more than 10 millimeters mercury. Up to 10 millimeters is considered normal with inspiration. But if it's more than that, that's pulsus paradoxus, and that's a sign of cardiac tamponade. Now, it can be a little tricky to measure because you kind of have to measure the systolic pressure during expiration and then measure it during inspiration. But if you find pulsus paradoxus, think about cardiac tamponade. Now, pulsus paradoxus is kind of similar to Kussmaul's sign because they're both a slight change in physical exam during inspiration, and they both deal with pericardial disease. So let's look at number 5 in the study guide and compare Kussmaul's sign side by side with pulsus paradoxus because they're similar but they're not the same. Kussmaul's sign is when you have jugular venous distension during inspiration. It's a right-sided heart problem. You inspire, but you're increasing jugular venous distension. Pulsus paradoxus is a decrease in the systolic blood pressure of more than 10 millimeters during inspiration. So both of these are occurring during inspiration. When you inspire, again, you're going to increase blood flow to the right side of the heart, but what results beyond that is different. The mechanism of Kussmaul's sign is decreased capacity of the right ventricle. With pulsus paradoxus, it's decreased capacity of the left ventricle. And the disease that causes Kussmaul's sign is generally constrictive pericarditis. Pulsus paradoxus is much more commonly due to tamponade. So don't get tripped up by that on your test. Know the differences between these two. So what kinds of things can cause pulsus paradoxus? Well, anything where you have exaggerated inspiration. Just makes sense. Exaggerated inspiration leads to exaggerated filling of the right side of your heart and exaggerated decreased filling in the left side of your heart and a decrease of blood pressure with inspiration. So we see it with cardiac tamponade, we see it with asthma, with croup, with obstructive sleep apnea, with severe COPD, and then rarely with pericarditis. Remember, that's less common. And then one other thing to know is that the classic EKG finding associated with cardiac tamponade is something called electrical alternans. It's just one of those buzzword things that's good to know. So electrical alternans means alternating electrical impulses. The QRS complex has beat-to-beat variability in amplitude. So one QRS might be really tall, the next one's really tiny, then tall, then tiny. So you have beat-to-beat variations in the QRS amplitude. It's pretty easy to spot. Now, electrical alternans is very specific to cardiac tamponade, but it's not very sensitive, which means that lots of people with tamponade don't have electrical alternans. If it's there, you can pretty much make the diagnosis of tamponade, but if it's not there, you can't rule out tamponade. I want to briefly mention the cardiovascular problems that syphilis can cause. Tertiary syphilis, when it affects the cardiovascular system, primarily affects the aorta. So syphilis disrupts the vasa vasorum, those blood vessels that supply the aorta. It can cause dilation both of the aorta itself and the aortic valve ring. Then dilation of that aortic root can lead to aortic regurgitation, but syphilis can also cause aortic stenosis. Syphilis can also cause thoracic aortic aneurysms and calcification of the aorta, and this classic tree bark appearance of the inside surface of the aorta. And then the last thing I want to discuss are some cardiac tumors. There are three main categories of cardiac tumors to discuss: metastatic tumors, myxomas, and rhabdomyomas. Now, cardiac tumors aren't all that common. The most common cardiac tumor is metastatic tumors from somewhere else. So we said a few minutes ago that melanoma likes to go to the heart, and lymphoma can also metastasize to the heart. But the most common primary cardiac tumor in adults is called a myxoma. Metastatic disease is the most common cardiac tumor overall, but if you're talking about primary cardiac tumors, myxomas are the most common. And myxomas usually occur in the left atrium, so I want you to remember the phrase left atrial myxoma. Put that all together in your mind. Left atrial myxoma looks like a little ball of tissue in the atrium. Clinically, this behaves kind of like a ball valve, and it can obstruct the mitral valve, and that can lead to syncopal episodes. So as blood is flowing into the ventricle during diastole, that myxoma ball is going to obstruct blood flow into the ventricle, which means that during systole, nothing's going to come out of the ventricle because you put no blood in there. So of course, that would cause a syncopal episode because you're not perfusing your brain. And then sometimes these myxomas can flop over into the left ventricle at the beginning of diastole, and that causes an early diastolic sound called a tumor plop. Now, I can't imagine they would actually expect you to recognize that sound on auscultation in your exam. Then rhabdomyomas are the other primary cardiac tumor, which is most common in children. So myxomas in adults, rhabdomyomas in children. And I want you to remember that rhabdomyomas are associated with tuberous sclerosis, along with astrocytoma, which is a brain tumor, and angiomyolipomas, which are renal tumors. So know those three tumors associated with tuberous sclerosis: rhabdomyoma, astrocytoma, and angiomyolipoma. So that's it for this video. Now it's time for the end of session quiz. So go over those questions and we'll talk through them together. All right, first question. Under what circumstances might you see pulsus paradoxus? So mainly I want you to think about cardiac tamponade, and rarely with pericarditis, but also think about asthma, croup, obstructive sleep apnea, and even severe COPD, anytime you have exaggerated inspiration. Next, what are the major criteria for the diagnosis of acute rheumatic fever? So the J was for joints, which is polyarthritis. The O is shaped like a heart for pancarditis. N is for nodules, those subcutaneous nodules. E is for erythema marginatum. And S is for Sydenham chorea, those choreiform movements in the face and the arms. And the last question, what heart pathology fits each of the following statements? So focal nodules of myocardial inflammation with multinucleate giant cells, those are the Aschoff bodies, which we saw in rheumatic heart disease. Chest pain and coarse rubbing heart sounds in a patient with a creatinine of 5 would be uremic pericarditis. Tree barking of the aorta is caused by tertiary syphilis. A child with fever, joint pain, cutaneous nodules 4 weeks after a throat infection is classic for acute rheumatic fever. ST segment elevation in all EKG leads is going to be seen in pericarditis. And EKG shows electrical alternans. Remember, that's very specific for cardiac tamponade, but we said it's not very sensitive. And then for the rapid-fire facts, we have granulomatous nodules in the heart. Again, those are the Aschoff bodies, which we saw in rheumatic heart disease. The most common primary cardiac tumor in adults is a left atrial myxoma. The most common primary cardiac tumor in children is a rhabdomyoma. And the most common cause of constrictive pericarditis in the U.S., it's lupus. In developing countries, it's tuberculosis. All right, that's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. First question here, what is the difference between primary biliary cholangitis and primary sclerosing cholangitis? So first we have primary biliary cholangitis. So this is an autoimmune disease, and it's associated with other autoimmune diseases like crest scleroderma. Now these patients typically have a positive AMA, and it's classically seen in middle-aged females. Now, what about our primary sclerosing cholangitis? So this has an unknown etiology. About 60% of cases are associated with positive P-ANCA. Now, it's seen primarily in males over the age of 40. It's associated with ulcerative colitis and cholangiocarcinoma. And you should remember the characteristic ERCP finding of alternating beating and stricturing. Next question. A patient develops ARDS from an occupational inhalation of nitrogen dioxide. What histologic change would be seen in a patient recovering from ARDS? So in ARDS, you're damaging your endothelial cells. You've got lots of inflammation. You're damaging your epithelial cells, your type 1 pneumocytes. So how would your body recover from all that damage? Well, the type 2 pneumocytes are going to proliferate to become the new type 1 pneumocytes. So proliferation of type 2 pneumocytes is what you would see here. Next, what is Reynolds pentad for cholangitis? So Reynolds pentad includes Charcot triad of fever, jaundice, and right upper quadrant pain, plus hypotension and altered mental status. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to discuss various types of vasculitis, which is a 5-star topic for step 1. These are definitely going to be on your test. So vasculitis means inflammation of the blood vessels. And the plural of vasculitis is vasculitides. Now, there's no such thing as a singular vasculitide. The singular is vasculitis. And most types of vasculitis cause inflammation of the arteries. You can have inflammation of large vessels, medium vessels, or small vessels. So let's start with the large vessel vasculitides. The first type of large vessel vasculitis we're going to discuss is called Takayasu arteritis. So what's the largest artery in the body? The aorta. And Takayasu arteritis is a granulomatous inflammation of arteries that come off of the aortic arch. So where do those branches go? Well, they go to the head and they go to the arms. So this is going to reduce blood flow to the arms and cause decreased pulses in the arms. So sometimes Takayasu arteritis is casually referred to as pulseless disease. That's a helpful phrase to remember. Many of these vasculitis syndromes have what we call a high-yield history. The history alone is going to give you some decent clues to the diagnosis. So for Takayasu arteritis, remember poor pulses in the extremities, and then also look for young Asian women in their teens and 20s. So it may be helpful to remember that Takayasu is a Japanese name, and that can help you think of young Asian women. And then all those A's in Takayasu, T-A-K-A-Y-A, all those A's remind me of the aorta. So if they give you a young Asian woman with poor peripheral pulses, think about Takayasu arteritis. And it's also associated with elevated ESR, or SED rate. The other large vessel vasculitis you should know about is giant cell arteritis. Now, it's also known as temporal arteritis, so know both of those names. Giant cell arteritis is particularly high yield, probably 4 stars all by itself. Giant cell arteritis is the most common form of vasculitis. So this is one you're likely going to test for clinically from time to time, although you may not actually see it very often. It causes inflammation of the branches of the external carotid, like the temporal arteries, and we classically see this in elderly women. Now, symptoms include a unilateral headache and sometimes jaw claudication. Jaw claudication means you're chewing your food and it kind of becomes painful and you have to stop. It's a lot like claudication in the legs from peripheral artery disease, where your legs start to hurt during activity because of ischemia. So jaw claudication occurs when the jaw muscles become ischemic because of the vasculitis. And as giant cell arteritis progresses, this jaw claudication becomes more and more severe. And the real reason that giant cell arteritis is a problem is that it can sometimes lead to occlusion of the ophthalmic artery, and that can lead to vision loss and even irreversible blindness. But it usually starts with that unilateral headache and jaw claudication. Now, the clinical findings include an elevated SED rate, so that's how you're going to screen for giant cell arteritis. The patient presents with unilateral headache and some jaw pain with chewing. You're going to need to check the SED rate to rule out giant cell arteritis. Now, if the SED rate's normal, this is probably not giant cell arteritis. If the SED rate's elevated, you want to keep giant cell arteritis in the differential. You might also find a palpable, tender temporal artery. And sometimes you're also going to see some muscle wasting in the temple, so that might be a good clue. So if they show you somebody who has temple wasting and a big prominent temporal artery, think about giant cell arteritis. About half of patients with giant cell arteritis have polymyalgia rheumatica, or PMR. Remember, polymyalgia rheumatica causes pain and joint stiffness, particularly in the neck, and the shoulder girdle, and possibly the hips. So think about proximal joints. And remember, the name polymyalgia suggests muscle pain, but this is actually joint pain. But again, PMR is associated with giant cell arteritis. Now, how do we diagnose giant cell arteritis? We said that SED rate is a decent screening test, but how do we make a definitive diagnosis? With a temporal artery biopsy. The reason this is called giant cell arteritis is that on biopsy you're going to see multinucleated giant cells and granulomas in the media and the adventitia of the temporal artery. And then the treatment is to give high-dose steroids for several months. So you start with a high dose of prednisone for about a month, and then you start to gradually taper it because you want to prevent that vision loss. Now let's move on to vasculitis of the medium-sized vessels, beginning with Kawasaki disease, which is also sometimes called mucocutaneous lymph node syndrome, which is a mouthful. Luckily, the name Kawasaki disease is still used pretty commonly. This is a disease of infants and young children, especially those of East Asian ethnicity, which is easy to remember because Kawasaki is another Japanese name. So Kawasaki causes fever that lasts at least 5 days, in addition to 4 of the following 5 findings. And the mnemonic for these findings is crash. So the C is for conjunctivitis, bilateral, non-exudative, painless conjunctivitis. The R is for rash on the trunk, which you see on the upper left. The A is for adenopathy of the cervical lymph nodes, which isn't really pictured here, but remember, this is called mucocutaneous lymph node syndrome. So that lymph node reminds you of lymphadenopathy. Then the S is for strawberry tongue, which is on the upper right, this beefy red tongue with a coarse texture to it. And then with that, you can have diffuse erythema of the mucous membranes, which you can see on the bottom left. This child's lips are just red and irritated looking. So there's the mucocutaneous part of this, changes in the lips and the oral mucosa. And then H is for hands and feet, which can show erythema or desquamation. And you see that on the bottom right, that desquamation of the fingertips. So desquamation of the hands and feet is another big clue for Kawasaki disease. There aren't really too many things that cause that. And some students like to make the mnemonic crash and burn, where the burn reminds you of the fever, which is almost always present. Something else to remember with Kawasaki disease is the potential for coronary artery aneurysms. That's what makes this disease so dangerous, because these coronary aneurysms can rupture, and that can be lethal. But those aneurysms can also pool blood within the aneurysm, and that can lead to thrombosis. And thrombosis of a coronary aneurysm can cause an MI. So these coronary aneurysms can either rupture or they can undergo thrombosis. So on your test, they might give you a coronary angiogram and expect you to recognize an aneurysm that you see there and then make the diagnosis from that. Now, we treat Kawasaki disease with IV immunoglobulin and aspirin. IV immunoglobulin, or IVIG, is essentially pooled antibodies. We take antibodies from hundreds of donors and give that to the patient, and that's going to suppress the patient's immune system, which is causing Kawasaki disease in the first place. So we give IVIG for Kawasaki disease and also for Guillain-Barré and a handful of other diseases. But aspirin is an important part of management as well. Now, we generally don't give aspirin to children because it might cause Reye's syndrome, but Kawasaki disease is a major exception. We give high-dose aspirin to prevent thrombosis of those coronary artery aneurysms. It's one of the few times you're ever going to give high-dose aspirin to children. The next type of vasculitis of medium-sized vessels is called thromboangiitis obliterans, which is sometimes called Berger disease. Buerger disease is vasculitis that affects small and medium peripheral arteries and veins, and it's seen in heavy smokers, especially youngish male smokers in their 40s. That may not seem so young to you, but it sounds pretty good to me. So that's your high-yield history. Vasculitis, heavy smoker, 40-year-old male, that's Buerger disease. Now the name thromboangiitis obliterans can also help you remember the clinical features. It's going to obliterate these vessels. So you're going to have intermittent claudication and superficial nodular phlebitis and cold sensitivity. This can cause severe pain in the affected joints, and it leads to gangrene and autoamputation of the digits, which is really nasty. And the treatment is to stop smoking. If the patient stops smoking, this just goes away. So far, these vasculitides have been pretty easy to recognize based on their specific clinical presentations. But the next one, polyarteritis nodosa, or PAN, can be pretty vague. PAN typically involves the kidneys and the visceral vessels, like the skin, the GI tract, and the heart, but it spares the lungs, and that's important. But because of this visceral involvement, you can get abdominal pain, melena, myalgias, neurological problems, very vague, nonspecific symptoms. But the tip-off for your exam, the high-yield history, is that PAN is associated with hepatitis B or hepatitis C infection. So because this presentation can be so vague, if they're going for PAN on your exam, they pretty much have to give you hepatitis in the question stem somewhere. So when you see Hep B with vasculitis, think about polyarteritis nodosa. And generally, ANCA is negative in patients with polyarteritis nodosa. We're going to talk about ANCA antibodies in detail very shortly, but a positive ANCA will pretty much rule out PAN as the diagnosis, and that can be helpful. Then the treatment for PAN is corticosteroids, plus or minus cyclophosphamide. So steroids can be used for a lot of vasculitides because they suppress the immune system. And cyclophosphamide will reduce the need for high-dose corticosteroids, so you can use a lower dose of steroids with cyclophosphamide than you could otherwise. Now we're moving to small vessel vasculitis, starting with Henoch-Schönlein purpura, or HSP. Now this is also called IgA vasculitis. So this is the most common form of systemic vasculitis in childhood. All of these are pretty rare, but this one's a little more common. About 50% of the time, HSP occurs in children with a recent upper respiratory infection, so that could be part of your high-yield history. HSP causes a rash of palpable purpura on the buttocks and legs. If you ever see or hear something described as palpable purpura, you should automatically think that you're dealing with some type of vasculitis. So lower extremity palpable purpura is your first clue that this is Henoch-Schönlein purpura. The second clue is arthralgias, typically in the knees. The third clue is abdominal pain, which is due to intestinal hemorrhage. And then a fourth clue is kidney disease. Those IgA immune complexes get deposited in the kidney, and this causes IgA nephropathy, which presents as nephritis and hematuria. We're going to talk about this again in the renal section, but the other name for IgA nephropathy is Buerger's disease. Now, this is not the same as B-U-E-R-G-E-R, Buerger disease. That was thromboangiitis obliterans in smokers. This is B-E-R-G-E-R, Buerger disease, the cornerstone of any nutritious breakfast. This is a tasty burger. But make sure you can recognize that classic presentation of lower extremity purpura, arthralgias, abdominal pain, and kidney disease. And generally, HSP is a temporary, self-limiting disease. Could I get some kind of tasty beverage to wash this down? The next one is called eosinophilic granulomatosis with polyangiitis, or you may recognize it by its older name, Churg-Strauss syndrome. This is a form of granulomatosis. So here you can see a multinucleate giant cell, which indicates a granuloma, and then you also see lots of pretty red eosinophils. So this is eosinophilic granulomatosis. Now we talked about the causes of eosinophilia in the immunology videos, and the mnemonic was Canada P, and one of those A's was for atopic diseases like asthma, and Churg-Strauss was one of those atopic diseases as well. So Churg-Strauss is associated with eosinophilia, and it's also associated with asthma. So if you see a vasculitis in a young asthmatic, think about Churg-Strauss syndrome. That's your high-yield history. You can also see sinusitis, skin lesions, and peripheral neuropathy, including foot drop and wrist drop. And these patients have a positive p-ANCA. So PAN has a negative p-ANCA. Churg-Strauss has a positive p-ANCA. So let's hold it right there for a second and talk about ANCA. ANCA stands for anti-neutrophil cytoplasmic antibodies, and you can have p-ANCA or c-ANCA. That just describes how they look on immunofluorescence. So p-ANCA is perinuclear anti-neutrophil cytoplasmic antibodies. So again, patients with eosinophilic granulomatosis with polyangiitis are going to have a positive P ANCA. And then C ANCA is cytoplasmic anti-neutrophil cytoplasmic antibodies. Generally speaking, P ANCA is made up of antibodies against an antigen called myeloperoxidase. So sometimes we call this MPO ANCA. And generally speaking, C ANCA is made up of antibodies against an antigen called proteinase 3, which we abbreviate PR3 ANCA. So you can call it C ANCA or P ANCA based on the pattern you see, or you can name it according to the target of the antibody, which would be MPO ANCA or PR3 ANCA. Now it doesn't always work out perfectly because occasionally MPO ANCA will give you a diffuse cytoplasmic or C ANCA pattern on immunofluorescence. And sometimes PR3 ANCA will be perinuclear. And then to confuse things further, we try to lump diseases into nice, neat categories and say that Churg-Strauss is always associated with P ANCA, but that's not always the case. But again, Churg-Strauss or eosinophilic granulomatosis with polyangiitis is generally associated with MPO ANCA, which is P ANCA. The next type of vasculitis has a similar name, which is granulomatosis with polyangiitis, or we sometimes abbreviate it GPA. The older name is Wegener's granulomatosis, but whatever you call it, this one is particularly high yield. This one's another 4-star topic all by itself, so make sure you know about granulomatosis with polyangiitis. The classic triad is focal necrotizing vasculitis, granulomas in the lung and upper airway, and glomerulonephritis. So there are only a couple of diseases that affect both the lungs and the kidneys. Think about GPA, granulomatosis with polyangiitis, and also think about Goodpasture syndrome. So how do you distinguish between them clinically? Well, in addition to affecting the lungs, GPA will also involve the upper airway. So you may find granulomas in the soft palate and the oropharynx, or in the nasal cavity, or the sinuses. You can also have collapse of the bridge of the nose, which is called saddle nose. And here's a lung biopsy from a patient with GPA, and here's a vessel right in the middle with lots of inflammatory cells like lymphocytes all around it, so this is a vasculitis. And then these pink areas are the multinucleate giant cells, where all those macrophages have merged together to form granulomas. So you have upper airways disease, you also have lung disease, and so you might have some dyspnea and hemoptysis with that, and then kidney disease with hematuria from the glomerulonephritis. And then with this one, instead of P ANCA, you have C ANCA, so that might be a very important clue for you. Then to treat GPA, we use cyclophosphamide and corticosteroids. Now, what was the other type of vasculitis that we treat with steroids plus cyclophosphamide? Polyarteritis nodosa. So the treatment for GPA is very similar to the treatment for polyarteritis nodosa. And then finally, there's microscopic polyangiitis, which is very similar to Wegener's. This affects the lungs and the kidneys, where it causes something called pauci-immune crescentic glomerulonephritis, and it can affect the upper airways, but less commonly. But the main thing that distinguishes these two diseases from one another is that microscopic polyangiitis is generally P ANCA positive, while in GPA, or Wegener's, the patient is usually C ANCA positive. I want to briefly cover one other disorder, which is technically not a type of vasculitis, but it shares some clinical features with some of them, and that's hereditary hemorrhagic telangiectasia. Or you may have heard the name Osler-Weber-Rondeau syndrome, or Rondeau-Osler-Weber syndrome, depending, I guess, on whether you like the Canadian physician Sir William Osler, who taught at Johns Hopkins and Oxford, or you prefer the French physician Henri Jules Louis Marie Rondeau, whose parents gave him a whopping 5 names. But the modern name is hereditary hemorrhagic telangiectasia, which tells you that it's hereditary, it's an autosomal dominant disease, it presents with hemorrhage, especially recurrent epistaxis or nosebleeds, sometimes GI bleeding or hematuria. This is due to vascular malformations in the mucosa, and those are prone to bleeding. And that hemorrhage can sometimes lead to iron deficiency anemia. These patients can also have vascular malformations called telangiectasias that are located in the skin or in the buccal mucosa. So if they give you a patient with nosebleeds and telangiectasias in the mouth, plus some iron deficiency anemia, think about hereditary hemorrhagic telangiectasia, especially if there's a family history of significant recurrent nosebleeds. Now it's time for the end of session quiz. So pause the video, answer those questions, then we'll go through them together. There's only one question in this quiz, but it's very high yield. If you don't know anything else about vasculitis, make sure you know these high yield associations. So weak pulses in the upper extremities is Takayasu arteritis. Granulomas of the lung, glomerulonephritis, and C ANCA positive, that's going to be granulomatosis with polyangiitis, or Wegener's granulomatosis. Necrotizing immune complex inflammation of the visceral and renal vessels is polyarteritis nodosa, and remember that's going to spare the lungs, and it's also ANCA negative. Vasculitis in a 2-year-old East Asian girl, think about Kawasaki disease. Vasculitis in a 20-year-old East Asian woman, think about Takayasu arteritis. Vasculitis in a young male smoker should make you think about Berger disease. In young asthmatics, you're going to think about eosinophilic granulomatosis with polyangiitis or Churg-Strauss syndrome. Infants and young children, and involves the coronary arteries, that's Kawasaki disease with those dangerous coronary aneurysms. The most common type of vasculitis is giant cell arteritis, also known as temporal arteritis. Often associated with hepatitis B infection is polyarteritis nodosa. Occlusion of the ophthalmic artery can lead to blindness, that's giant cell arteritis again. And perforation of the nasal septum is most likely granulomatosis with polyangiitis or Wegener's, with that upper airway involvement. And then unilateral headache plus jaw claudication is a big tip-off for giant cell arteritis. And then for our rapid-fire facts, we have C. ANCA is associated with granulomatosis with polyangiitis or Wegener's granulomatosis. And then P. ANCA is associated with both eosinophilic granulomatosis with polyangiitis, which is Churg-Strauss syndrome, and that's associated with microscopic polyangiitis. The treatment for thromboangiitis obliterans is smoking cessation, and the treatment for giant cell arteritis is high-dose steroids. And that's it for now. I'll see you next time.
It's time for another warm-up. Let's get going. First question here, which autoimmune disorder is associated with each of the following types of antibodies? So first we have anti-TSH receptor antibodies, that's going to be seen in Graves' disease. Anti-mitochondrial antibodies, that's going to be seen in primary biliary cholangitis. Anti-centromere antibodies, that's going to be seen in crest scleroderma. Anti-histone antibodies, going to be seen in drug-induced lupus. And then anti-smooth muscle antibodies are going to be seen in autoimmune hepatitis. Next question, what is the cause of chronic granulomatous disease, and then what are the consequences of chronic granulomatous disease? So first we have the causes. So this is where you have a lack of NADPH oxidase activity. So phagocytes, like neutrophils, are able to engulf that bacteria, but they can't generate the free radicals to actually kill the bacteria. So basically you end up with what are called impotent phagocytes that cannot kill microbes that are catalase positive. And then what are the consequences of chronic granulomatous disease? Well, it makes patients especially susceptible to infections with Staph aureus and Aspergillus. So knowing both the defect enzyme, so the NADPH oxidase, and the resulting pathogens, Staph aureus and Aspergillus, very important there. Next question, what are the mechanism and time frame of acute transplant rejection? So the mechanism is that cytotoxic T cells react to MHC. So this is a cell-mediated process, and the time frame is usually weeks following transplantation. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to cover a handful of leftover vascular diseases, like vascular tumors. Not terribly high yield, so we're going to cover this pretty quickly. Let's start with a patient profile. This patient profile is called the Shivering Scoutmaster. A volunteer leader in a local youth organization comes to the physician complaining that when he's camping in the winter months, his right middle finger becomes quite cold and turns first white, then dusky blue. This discoloration often spreads to other fingers on both hands. After about 15 minutes of warming his hands, the fingers become quite red before returning to their normal color. What's the most likely diagnosis, and how can this disorder be treated? Well, you probably guessed right away that this represents Raynaud phenomenon, which is caused by arterial vasospasm leading to poor blood flow to the skin of the fingers and possibly the toes. It's generally brought on by cold temperatures or maybe by emotional stress because of sympathetic activation. It might bother the patient more in the wintertime, or they might get it when they stick their hand into the freezer or the refrigerator to grab something cold. The arterial spasm causes pallor, where the fingers turn pale and white, followed by cyanosis, where the fingers turn blue because there's deoxygenated blood trapped in there. And then when the spasm resolves, the fingers are reperfused and they get very red or hyperemic. And this is an intermittent process because it does go away after you warm up the hands. Raynaud phenomenon can occur all by itself, or it can be a feature of other diseases, such as mixed connective tissue disease, or Berger disease, thromboangiitis obliterans, or lupus, or crest scleroderma. Then the treatment for Raynaud phenomenon, first and foremost, is to keep the hands warm and avoid the cold, because it's the shift from warm to cold that really triggers the vasospasm. Now, if avoidance doesn't work, you can use dihydropyridine calcium channel blockers like amlodipine or nifedipine, because they act as vasodilators. The other thing we're going to cover are some vascular malformations and vascular tumors. So this is going to be a little like show and tell. Now, you may see a question asking you to diagnose a particular red skin lesion, and this is going to be your differential for those. So let's start with Sturge-Weber disease. Sturge-Weber disease is a congenital disorder that affects capillaries, and it causes a type of intracranial AV malformation called a leptomeningeal angioma, which can affect the meninges and also the eye. So you can have a purplish port wine stain in the ophthalmic division of the trigeminal nerve, and that port wine stain indicates that there's a vascular malformation deeper in the brain. This can be associated with seizures, with early onset glaucoma, and also intellectual disability, or what we used to call mental retardation, and hemiplegia as well. So lots of different CNS problems. A strawberry hemangioma is a benign hemangioma of the cutaneous surface capillaries, and it's seen in infants. So initially this grows as the child grows for maybe weeks or up to 6 months, and then it's going to spontaneously regress. These are completely gone by age 8 or so. Sometimes they're gone by 4 or 5. Usually you don't have to do anything about them unless they're causing some airway obstruction or something like that. Now, don't confuse this with a port wine stain. Strawberry hemangiomas are pinkish or red like strawberries, and they're going to go away. Port wine stains are darker, more purple, and they don't go away. A cherry hemangioma is a benign hemangioma of the cutaneous surface capillaries. So you may find some of these on your own skin. It looks like a mole except it's red, and it does not regress. And you tend to get more of these as you get older, and these are often seen in the elderly. A pyogenic granuloma is a raised capillary hemangioma that looks a bit like a red polyp on the skin, and this can ulcerate and bleed. These are especially associated with pregnancy and trauma, so that's a pretty good historical clue. They tend to develop on the lips and gums during pregnancy. All right, those are all the red vascular lesions, but let's keep going with a few other vascular tumors. A cystic hygroma is a cavernous hemangioma of the neck, often associated with Turner syndrome, but that's not the only time you're ever going to see it. Remember, Turner syndrome is associated with 2 neck pathologies, cystic hygroma and also webbing of the neck. Cystic hygromas can be very small, or they can be very, very large and very debilitating. A glomus tumor is a benign, painful reddish-blue tumor on the hands, often under the fingernails. Bacillary angiomatosis is caused by Bartonella henselae. It's benign, but it can be mistaken for Kaposi sarcoma in AIDS patients, and vice versa.
There are several different types of Kaposi sarcoma, or KS. There's classic KS, which is an indolent cutaneous tumor that's seen in older men of Mediterranean descent, usually found on the legs. There's the endemic KS that we see in sub-Saharan Africa, and there's the epidemic or AIDS-related form of KS. Kaposi sarcoma is one of the AIDS-defining illnesses, so if an HIV-positive patient has Kaposi sarcoma, that can now be classified as AIDS. And then all of these are caused by human herpes virus 8 infection. This causes proliferation of vessels and lymphatics on the skin, and also sometimes on the internal organs like the lungs. And again, it's frequently mistaken for bacillary angiomatosis, but bacillary angiomatosis is associated with Bartonella henselae infection. KS is much more common in HIV patients, but I guess the important message is that you really need to do a biopsy to make the definitive diagnosis of KS versus bacillary angiomatosis. And then angiosarcoma is a blood vessel malignancy, usually in the face or the scalp or the neck, and also the breast. These are definitely associated with prior radiation therapy. So a woman that had a lumpectomy and radiation for a small breast cancer might be at increased risk of developing an angiosarcoma of the breast or the chest wall. And these like to metastasize to the bone or to the brain, so they can really kind of turn up almost anywhere. And then a lymphangiosarcoma is a lymphatic malignancy associated with persistent lymphedema, like a woman who had a mastectomy, and then she developed persistent lymphedema, and then she got lymphangiosarcoma. All right, let's take a look at the end of session quiz. First question, which disorders are commonly discovered in patients with Raynaud phenomenon? So we said lupus, crest scleroderma, Berger disease, and mixed connective tissue disease. And the last question, which vascular tumor fits each of the following descriptions? The first one, a benign, red, raised lesion about the size of a mole in older patients, is a cherry hemangioma. A red raised area present at birth, which increases in size initially and eventually regresses, is a strawberry hemangioma. A lesion caused by lymphoangiogenic growth factors in an HIV patient is Kaposi sarcoma. Polypoid red lesion found in pregnancy or after trauma is a pyogenic granuloma. A benign, painful red-blue tumor under the fingernails is a glomus tumor.
Cavernous lymphangioma associated with Turner syndrome is a cystic hygroma. And a skin papule in an AIDS patient caused by Bartonella is bacillary angiomatosis. All right, that's the end of the cardiovascular section. We'll see you next time.